Well, good afternoon, everyone. My iPhone says it's 5 o'clock, so time to convene our meeting of the Knoxville County Board of Health for October the 28th. And so first order of business is the call to order. And next, we will have a roll call. And Narda, if you are on board, if you will help us with the roll call, please.
Yes, sir. This is Narda Capicelli. We're doing the roll call for October 28th, Board of Health. Dr. Diana Drake. Here. Dr. Gupta.
Here.
Dr. Hurt.
Here.
Mayor Glenn Jacobs.
Here.
Dr. O'Brien.
Here.
Ms. Roma.
Here.
Dr. Shamia.
Here.
Dr. Sousa.
Here.
Ms. Wagner.
Present.
Dr. Buchanan.
Here.
Thank you. All present and accounted for. 10 members here.
Very good. We have established a quorum. So the next order of business is approval of the minutes for the October 14, 2020 meeting. Those have been electronically distributed. And has everybody had a chance to take a look at them? As I think maybe Dr. Buchanan has done in the past, I will abstain on approving them since I was not present, but I looked over them, and in general, I think that reflects what the meeting was about, but I'm going to have you all make that decision. So we need to have a motion for approval of those minutes in a second, and any discussion then.
I'll motion to approve.
I second it.
We have a motion and a second. Is there any discussion on the minutes of the meeting of October 14? Any additions, corrections, substitutions?
So on page 5, the bottom, Ms. Sturm's name is misspelled, the last sentence on that page. It's Strum instead of Sturm. So that's the only change that I can see.
Okay. Any other additions or corrections? If not, we'll sort of take as a friendly amendment that spelling correction and still have that motion and second on the floor. Any other discussion on that or any other additions or corrections? If not, we'll go ahead with a roll call vote. And Narda, if you'll go through the roll with us, please.
Yes, this is Narda Capicelli taking vote for the acceptance of the minutes from October 14th. Dr. Drake?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs? Mayor
Yes.
Jacobs?
Yes.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Sousa?
Yes.
Ms. Wagner?
Yes.
And Dr. Buchanan?
Yes.
Thank you.
Very, very good. You have approved those minutes from October 14. The next item on the agenda is to set the agenda, and you have had that either electronically or by paper before you. And we will need to have a motion for approval and a second to begin any discussion on the agenda if there's any changes in it.
I'll motion to accept the agenda.
Second.
I second it.
So we have a motion and a second. Any discussion on the agenda itself, including any changes in order, additions, or corrections? If there are none, I sense we're ready to vote. So Narda, if you will go through the roll call one more time for us, please.
Yes, this is Narda Capicelli, and we're setting the agenda. Dr. Drake?
Yes.
Dr. Gotcher?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs?
Yes.
Dr. O'Brien? Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia,
Yes.
Dr. Sousa,
Yes.
Ms. Wagner,
Yes.
Dr. Buchanan.
Yes.
Thank you. You passed 10-0, unanimous.
You have set the agenda for this evening's meeting, and the next item on the agenda is discussion of the Tennessee Pulse Survey with Dr. Katie Cahill, who is the Associate Director of Howard H. Baker Jr. Center for Public Policy.
Thank you so much for having me. Is it all right for me to proceed?
It certainly is. Thank you for being here. Thanks for your presentation in advance. Thank you.
First, I want to go ahead and share the CORE19 website. The CORE19 stands for Coronavirus Outbreak Response Experts, and it's a group of faculty and researchers at the University of Tennessee, Knoxville, who formed in mid-March, actually quite at the beginning of the global pandemic, to provide their expertise to the community, to local officials and state level officials about research on coronaviruses generally and coronavirus 19 specifically. And so I want to show some of that data and work we've done. And are you able to see the website right now?
Yes.
Yes.
Right. So one thing I want to highlight is we do have this data dashboard. It's updated on a daily basis using the Tennessee public health data. It is interactive. Users can actually click through. They can look at positivity rates, active cases. They can also look at share of cases by age, case fatality rates by age, hospitalizations per day, deaths per day. We also have this leaderboard on the left-hand side, and then scrolling over, there's additional information about testing trends in the state of Tennessee. And as I said, this is updated on a daily basis, and I think it's a really excellent way for community members to interact and to see the data for themselves. And so that's one thing I wanted to highlight. We have had more than 25,000 unique users in the last 90 days interact with this data dashboard. The other thing that I wanted to highlight was on the left-hand side, you can see there's a tracking map. This is done in partnership with CORE19 by the Tennessee State Data Science Center, which is part of UT, and it actually has a map by county with some of the same information that's also on the data dashboard, but is also geographic. So you can click on Knoxville, for example, and it will bring up total cases, new cases, as well as other information. At the bottom here, there's some trend lines, etc. Also on the website, we have policy briefs, which we try and update as possible, information about the experts, and then what I'm going to speak about this evening, which is the Tennessee Pulse Survey. And anyone can go and get the survey data. They can view the data on through a series of, there's actually been 6 waves, and I'll talk about that in a moment. They can actually click right here. They can scroll through, again, in an interactive format with screens for overall trends broken down by age, gender, race, and region. And anyone can view that data. If someone wishes to actually get the data, the backend data for themselves to do their own analyses, they can email us at core19@utk.edu, and it's publicly available. So now I'm going to share my presentation. And what I tried to do this evening was just to provide some highlights. I'm happy to answer questions at the end of this presentation. So as Dr. Gotcher mentioned, I'm Dr. Katie Cahill. I'm the Associate Director of the Howard H. Baker Jr. Center for Public Policy. My PhD is in public policy with an emphasis in public health, and I joined the center in 2017, so I've been here for a couple of years. So in terms of background on the Tennessee Pulse Survey, it was developed in partnership with Governor Bill Lee's Economic Recovery Group, as well as the Baker Center and the Social Work Office of Research and Public Service at the University of Tennessee, Knoxville. And as I mentioned, it's part of that CORE19 working group at the university. It's a statewide web-based survey of more than 1,000 Tennesseans each wave, which enables statistically valid segmentation, as I showed you, by age, race, gender, and region. And region here is an 89 county grouping labeled rural, and a 6 county metro grouping. The 6 counties are those that have independent health boards. So far, we've conducted 6 survey waves, and they're available, as I noted, on the center's CORE19 website, as well as a time series comparison. I'm going to show some of the time series data today. So you can look at each wave individually or also look at how the questions have, answers to the questions have changed over time using that time series link. So data collection on wave 7 actually was just completed last week and will be posted to the website based on October responses once the information has been processed, I would guess in the next week and a half or so. So the survey provides data on Tennesseans' attitudes towards reopening of the economy to help guide public policy. And that's why we were invited by the governor's office to assist with this effort. We fielded the first survey in May, and surveys have been ongoing since then. So here are the key findings. This is based on both the most recent data as well as the overall trends. The first is that a majority of Tennesseans are extremely or very concerned about the spread of COVID-19. Only 9% actually reported being less concerned than they were 2 weeks ago. So this is data from September. So this would have been early September compared to later on in September. But this is consistent across all of our waves since May. Tennesseans report being extremely or very concerned, and very few report that that concern is diminishing. Tennesseans are most concerned about the health of their family over their own health, employment, or paying bills, as well as some other options that we provided to them, such as being able to secure goods at the grocery store that they may need for their families, or being able to receive medical care. Most report taking steps to protect themselves, including staying at home when ill, 82%, wearing masks, 85%, and 88% actually report that masks work. Some, around 43%, say that they work to protect both themselves and others, while some say, basically split on the other 40%, around 20% say it works to protect others from germs that you may have, while others say it's protecting you from germs that others would have. So reports of mask wearing during various activities has actually increased over the last few months, and I'm going to talk more about that. Tennesseans report wanting businesses to take steps to protect customers and employees from the spread of the virus, with more than 70% expressing concern that easing restrictions will lead to an increase in caseloads. And that's a very consistent finding across waves. About half are most concerned about the economy, and about half are most concerned about the health impact of COVID-19 when it's put in sort of more distant terms, so not about their personal concerns, but about the larger country as a whole. And attitudes have largely, as I noted, been stable over time, but there is evidence of declining optimism since summer, which is the question looking ahead 2 weeks from now. Do you think things will be better, worse, or about the same? And this is potentially driven by rising caseloads. So in terms of steps that an overwhelming majority of Tennesseans are reporting to taking to prevent the spread of the virus, first is wearing masks or face coverings in public. In the most recent wave of September, 85%, as I noted, of Tennesseans reported wearing masks or face coverings in public for the purpose of preventing spread. 82% reported staying home to prevent spread, 77% reported practicing social distancing, and 76% reported washing or sanitizing hands while in public to prevent the spread of the virus. These are steps that more than half of consumers want businesses and employees to take at those businesses. And here it's actually 68% for businesses to provide wipes and or hand sanitizer to consumers. And then what I've done here is actually, so requiring employees to wear face coverings in July was actually below providing wipes and or hand sanitizers. And it is now taken the lead just by 1%, which is within the margin of error. But I think it is notable that 69% would like businesses to require their employees to wear face coverings. 63% would like businesses to screen employees for symptoms. 62% would like a frequency of cleaning the workplace. 62% would like businesses to enforce social distancing amongst customers of that business. 56%, now we're kind of dropping down into just over half of respondents, would like businesses to limit the number of patrons, install plastic barriers, and allow remote work when possible. So that gives a sense both on the personal actions that Tennesseans are taking to prevent the spread of the virus, as well as the sense of what Tennesseans seem to want businesses and their employees to do in order to help in that effort. So this is a graph. This is one of the time series examples about how often, the question is, how often do you wear a mask when doing each of the activities below? So we, in partnership with the Economic Recovery Group, we asked about a range of economic related activities, such as eating at dine-in restaurants, going to department stores, et cetera. And if this was the interactive platform, you could actually click over the 3 waves, so wave 4, wave 5, and wave 6, where this question has been asked, but here it's just a static image. So you can see that over half of Tennesseans report that they always wear a mask when they're eating at a dine-in restaurant. A overwhelming majority, nearly 70%, when they are going shopping at department stores, and also, over half going to in-person church services, attending large public events, going to movie theaters. And then we see definitely at work, or at the office or work site, as well as when attending in-person classes at a school or university. And so in many ways, the reported mask wearing behavior has actually increased over the last 3 waves. We've seen an increase across the categories. But what you also note here is that it seems that people are taking reasonable measures in terms of knowing when a mask is really, really important versus maybe less so because there's more distance between themselves and others. For example, you can see here, engaging in outdoor activities, only just over 30% of the time do people report that they always wear a mask. And so obviously in outdoors where there are fewer people and you have more opportunity to social distance, mask wearing is less important than when you're in crowded spaces. This question we started asking in wave 4 at the direction of the governor's office. Are you supportive of a mask requirement in your local community? And we can see here that very consistently over 70%, so 3 and 4, 3 and 4 Tennesseans say that yes, in fact, they are supportive of a mask requirement, a local mask requirement in their community. So the different colors here are the different waves. We have yes, no, and not sure. Importantly here is that that doesn't, just because 3 and 4 are supportive of a mask requirement doesn't mean that 1 and 4 are against. In fact, there's a degree of people who are unsure. And so in the most recent September data, 15% said no, and 7% said they weren't sure. But really, near 78%, nearly 80% of Tennesseans said that they supported a mask requirement in their local community. The governor's office asked us to break this down between that regional variable, so between urban and rural. And what we found was that while there was slightly less support in rural counties versus those metro counties, it was still over 70% in those those rural counties, the 89 rural counties. In addition to that, we did an assessment about whether or not those no answers were, a subset of individuals with specific demographics, and we found that no, actually they mirror their community. It's just a smaller group, a small subset of people who are not supportive of a mask requirement. So across activities, all of the activities that were listed in the slides, eating at a dine-in restaurant, going to church activities, going to large-scale public events, going to work, going to school, all of those, 1 in 5 Tennesseans, it's actually the most common response out of those options provided, report that they will not be ready to re-engage until caseloads are steadily going down. And so that is the key metric that 1 in 5 Tennesseans are looking for. There are a smaller group of people who are about 10% across surveys, between 10 and 15%, who are waiting for a vaccine or medication, 15% waiting for a vaccine, and around 10 to 15% who are waiting for medication that's effective in the treatment. And so most people are either, looking for cases to steadily go down or something even more certain, like a vaccine or a course of medicine that can treat the virus, in order to re-engage in normal activities. So in terms of whether or not people would accept a coronavirus vaccine if it was available and made for free, we see that actually the definitely category definitely would get the vaccine, which is the top here, has gone down over the last 3 waves when this question has been asked really precipitously given that the steadiness of most of the other attitudes reported in the data. And so that is something to be watching and to be thinking about potentially as the county health board about how, communication strategies around when a vaccine is available, about making sure that people are able to trust it. That has always been the case with vaccines. Vaccines have a long history of public skepticism in public health. And so definitely not a new challenge, but an important one to potentially consider, given the precipitous decline here of people willing to accept even a free vaccine. So looking ahead 2 weeks from now, I highlighted this question before, do you think that the situation will be better, about the same, or worse? And what we see is, although while most people, 65% in the most recent data, say the situation will be about the same 2 weeks from now, which is right now actually, only 19% think it will be better. And that's gone down since May. So you can see that gray bar, May, the end of May, people thought that things were going to be getting better. And although we see a slight uptick since July, we can see that most people are fairly skeptical that things will be getting better. They either think it will be the same as it is now or be getting worse. So it seems that I have skipped a few slides. Nope, maybe I did not. I think I've got them all. Okay, great. So those are all of my slides. I'm happy to answer any questions that anyone has.
Thank you, Dr. Cahill. It was a great presentation. Any questions, comments from the board?
This is Maria Hurd. I have a question. Thank you. That was very informative. My question is, if the majority, if I understand you correctly, the data correctly, if the majority of Tennesseans are in support of mask wearing and they want basically everyone else to wear a mask, until there is sufficient evidence that caseloads are steadily decreasing. My question is, do we happen to know what most of our fellow citizens in Tennessee regard as, a reliable source of information to trust that indeed the caseloads are decreasing? Do we have any kind of data or information about that?
Yes, thank you so much for asking that question. We do ask which source do you trust the most for information related to the pandemic, and CDC is the #1 source by far that people in Tennessee trust about the pandemic and coronavirus and about next steps. I can actually, if you'll give me just a moment, I can pull up that question. Let me see here. Maybe I will refer you. Actually, I'll just refer you to the website. That way I can make sure that I answer more questions. But yes, we ask a series of questions about who people trust, including state government, local government, federal government, the CDC, the news media. Probably is no surprise the news media is around the bottom in terms of trust as a trustworthy source. But definitely the CDC is very much the leader on that
Great.
issue.
Thank you.
Any other questions, comments? Dr. Cahill, how often are those waves reproduced? Is that monthly or every other month, or about how often is that being done?
Yes, sir. So at the beginning, it was a weekly. It was every other week. But now, since July, we moved to a once-a-month model, and so it's once a month.
Okay.
And actually, our intention is to our agreement with the state is to only do 8. So we only have 1 more in November that we're planning on. That may change, but for now, we plan to end the survey in November. I think predominantly probably because the attitudes have been so very consistent. That it's unlikely that we will discover sort of new things about where people are with the pandemic.
If it's okay, we may wish to have you back for that report on that last wave and tell us whether that'll be continuing or not, because this is really valuable information, a lot of which we're seeing for the first time. So great information. Thank you.
You are most welcome. And I'm always happy to come back. Like I said, we'll have the October wave posted in a week and a half or so, 2 weeks at the most, and then we'll be looking for that November wave, the last week of November or the first week of December. And so right into the holidays, which might be a really important time to be having conversations about the activities that people intend to engage in.
Great. We look forward to your input. Thank you very much. Any other questions from the board for Dr. Cahill? If not, again, we really appreciate it. Thanks for your help in our deliberations. And again, we look forward to hearing from you in the future. Thank you.
Thank you so much for the invitation.
So next on the agenda, item 7 is the Knox County Health Department benchmark presentation by Dr. Buchanan. So Dr. Buchanan, if you have the info, take it away.
Okay. As usual, I'll go and get started with our local data as Charity pulls up the information for you. So here we are. So we have 105 new confirmed cases since yesterday, giving us a total of 12,828 confirmed cases in Knox County since March, with 626 probable cases. 11,879 of our cases are considered inactive, giving us 1,472 active cases. 465 individuals have been hospitalized at some point in their illness. 69 Knox County residents are currently hospitalized. And unfortunately, we have 2 additional deaths to report today, giving our total deaths, moving our total deaths up to 103. So move on to the benchmarks. First benchmark is sustained reduction or stability in new cases for 14 days. Over this time period, we experienced 6 red flags and 1 yellow flag, but they weren't on consecutive days. Over the past 14 days, we've seen an average of 114 new cases a day. And over the past 7 days, that number has increased to an average of 129 cases a day. Because of these factors, we're reporting this benchmark as yellow. Second benchmark, community-wide and sustained and increased diagnostic testing with consistent or decreased test result report turnaround time. Regarding testing, there were 5 red flags and 2 yellow flags in this time period, with some of these falling on consecutive days. Since the beginning of October, overall testing has trended consistently, but at a lower volume than we'd like to see. So it's been consistent, but just the volume has not been as high as we'd like it to be. Regarding lab turnaround time, there were 2 flags on consecutive days. The average turnaround time remains consistent around 2.5 days. Because of these factors, we're continue to have this benchmark at yellow. On to the third benchmark, sustained or increased public health capability. For this benchmark, we aim to initiate investigations for new cases within 24 hours and close contacts within 48 hours. With our EPI support team, we continue to be able to initiate investigations as in the time frame we would like to. And because of that, this benchmark remains at green. Our fourth benchmark, healthcare system capabilities remain within current or forecasted surge capacity. During the past 14 days, we have noted 1 red flag and 3 consecutive yellow flags for inpatients with COVID-19. These numbers are the highest we have seen yet and have remained at a consistently high level. Additionally, we noted 4 consecutive red flags for patients in the ICU. 3 consecutive red flags and 2 yellow flags were noted for COVID patients requiring ventilators. These flags are based on our published metrics that illustrate statistically significant shifts in the data. After speaking with our hospital partners, they have recommended that this benchmark remain at yellow because they are still within their ability to manage the current numbers of patients. And as usual, Dr. Shami will probably have a little more to say about that in his report. Our fifth benchmark, sustained or decreased COVID-19 related death for identified positive or probable cases. Over the past 2 weeks, we've seen 12 deaths, with 4 in the last 7 days. The information available leads us to represent this benchmark as yellow. Under our supplemental data section, the first chart shows new daily COVID cases per 100,000 population. As of today, our 14-day trend line shows 24 cases per 100,000, and our 7-day trend line shows 27 cases per 100,000, which I believe is that up or down from last week?
I wasn't here.
That's right. Okay.
I think it's up though.
I do too.
Looking at it, I would guess it's up.
I think that's up from last week. The second chart shows the percent positive for COVID-19. This data is received from the Tennessee Department of Health. The 7-day average for percent positive in Knox County is actually down this from 2 weeks ago at 9.9%. 2 weeks ago it was about 12%. I think the other note that I'd like to talk about with the data is if you looked at the White House report, Knox County has moved from orange to red in the past 2 weeks. And so I think that's something for us to consider as we discuss and we get further into our discussions. So, any questions about our local data?
Questions from the board? If not, Dr. Buchanan, I have a question to you, and it'll also go to Dr. Shamia. When we look at cases per 100,000 population, how does that figure, we're looking at, is it 23 cases per 100,000?
It was, the 14-day trend line is 24 and the 7-day trend line is 27. So it depends on how long of a period you look at. So that 14-day trend line is generally a little more stable because it's a longer period of time. So we're 24 to 27 cases per 100,000.
I may be jumping ahead a little bit on Dr. Shamia's information. How does that compare with regional figures?
I'm sorry, I couldn't understand you.
How does that compare with regional hospital figures or regional figures?
The regional cases per 100,000 or hospitalizations?
Well, let's start with just cases per 100,000.
We could probably try to find that on the Tennessee Department. Is that available on the TDH website?
Hi, this is Charity Menifee. We could look at it. We can, they have a county snapshot for each of those counties. Overall, the trend from discussions Monday on the state call was everybody is up. So there's trends both in the rural regions and the metro regions. That was pretty much the theme of Monday's call.
You know, statewide, looking at some of the rural counties that are, at least, for example, Maury County was at capacity enough that they did away with elective procedures at
Yes.
the hospital in Columbia. And I'm wondering, in most instances in rural counties, if they start to peak at local hospitals, you know, all of the regional hospitals here get that overflow, and that might negatively affect if we have high numbers outside of Knox County.
Mm-hmm.
Dr. Gocher, this is James Shamia. I absolutely think that's true, and I think that in just a minute the regional inpatient census we can go through, but certainly as healthcare stress shifts around in a 21 county area, give or take a few counties, then when one area gets stressed, then that those patients can tend to land somewhere else. And if they're not stressed at that point, then they are potentially going to become stressed due to that increased patient volume.
Okay. Thanks. Any other comments regarding our benchmark data for this meeting? If not, as usual, Dr. Buchanan, thank you very much for all that hard work on the benchmark presentation. And next item on the agenda is the University of Tennessee Medical Center Knoxville data update from Dr. Shamia. So, Dr. Shamia, if you will give us your latest information.
Thank you.
On its way.
So while the slides are being brought up, I will say that although we haven't yet formally adopted a stratified yellow, we did talk about that this morning from a hospital capacity standpoint, and we really landed on we would be yellow improving, yellow stable, or yellow worsening, and based on the overall healthcare situation, we considered it yellow worsening today. And the other thing I do want us to always think about is that when we talk about kind of the healthcare stress on the system, that's not just about COVID-19 patients. I know that's where the narrative tends to focus, but it's about all patients, and it's also about staff. And so something as simple as some increased staff that are out sick, just like every other industry has people out sick, that is an element that can have an impact as well. And I'll get to that here in just a few minutes. I've got a little more today to talk about than in some prior weeks. So next slide, please. So first, just the new cases. And again, these first few slides really just show what Dr. Buchanan talked about in a slightly different way. But you see in this most recent week, Knox County had its highest week, and this data comes from TDH, but it broke that 1,000 mark for a week. The Knoxville district, those counties in the box, also had a very significant increase in the past week. So next slide, please. I think this is important. We always look at it, but I want to make even more of a point of it today, is that you see in the lower right-hand corner now pretty steadily that those new cases are being significantly driven by the 51 and older age group. That's important from a hospital perspective, just because those are the people that are more likely to be hospitalized. But when you look across, it wouldn't necessarily make sense that, well, why would the 31 to 40 and 41 to 50 just not be experiencing COVID? So what I infer from this, and it is an inference, but that we all sense that the primary driver for people getting tests right now is symptoms. And so that it may be that those that are 51 and older are more likely to be symptomatic, more likely to be tested. But that also means that if symptoms are driving testing, then from a public health contact tracing perspective, we're probably not able to do as much of that as we would like. And that certainly speaks to our positivity. Our positivity rate speaks to that as well, being as high as it is. Next slide, please. So when you look, of course, Knox County in the lower right is exactly what I just showed. But what this shows is that Shelby and Davidson have started to spike significantly. And remember that the y-axis and all these are different. So the populations are different, but the trends are similar. Hamilton has kind of been a little more level, but the same thing seems to be happening there. So what we are seeing, and I believe what some of the governor, I didn't get to watch all of the governor's press conference, but it is truly becoming a statewide issue. Initially, months ago, it was in Middle and West Tennessee. Then there was a focus on East Tennessee. I think it's progressively and rapidly becoming all of Tennessee that's seeing the rise. Next slide, please. So I mentioned at our last meeting that this data lags. These are new hospitalizations by week and month, but it does show now in the last, since our last meeting, we've had significant increase in week-to-week hospitalizations, both in the county and the district. And then now we'll get to census. Next slide, please. So a few things to note here. So we hit another all-time peak at 236 patients. I've mentioned to you before that all of the major health systems are on a daily capacity call at 1 o'clock where we compare both our COVID census. If you go back a slide, please. Our COVID census, as well as our overall capacity. And those numbers don't match these perfectly just because the counties aren't precisely the same. But the group as a whole saw a peak at around the same time, and it has stabilized just a bit. The other thing I point out there is when we had our prior peak of 185, you saw how quickly it goes up and how much longer it takes for it to go down. And then the rise mirrored almost exactly the rise before, how quickly it went up. And so when you look at a variety of societal factors, if that does come down, the expectation is it would go down slower than it goes up. Next slide, please. So then these are the projections, and I've, I increasingly week over week, there's probably not a lot of value at looking at this, only if we see 4 or 5 weeks in a row where it just keeps going, either keeps getting progressively worse or getting progressively better, would I see this helpful. But you see how much just the flattening of the last 5 to 7 days has brought that last projection of 380 down to 193. And all it does is take 5 to 7 days of rise to send it back up into the 300-400 range. So I'm showing this to you because I've shown it every time, but I don't want us to make too much of it. Next slide, please. So I did want to go into, just from a understanding perspective, both perspective in Tennessee, and then also just kind of the way this really works for a hospital, into a little more detail. So Dr. Goetcher mentioned this, but we have seen in our region some impacts already. Maury Regional has suspended some elective procedures that require overnight stay due to bed shortage. Cookeville Regional has suspended some of their elective procedures due to their COVID-19 census. And they, in their press release, expressed concern about the impact to patients that have illnesses other than COVID-19, that some of those procedures, those electives may be delayed, similar to what happened in the spring. Holston Valley is the same story. Ballad Health were really the first to come out last week with a press conference describing some concern they had, and that may be moving to other hospitals. I think here in Knox County, we've been able to avoid these situations so far because I really do feel like we've set up really excellent collaboration by our hospitals and the health department. But what in reality has happened on certain days is that there'll be one hospital or system that has more tension than the other. And so it just seems to have worked itself out because there's still enough excess capacity in the system, but we've definitely seen some very busy emergency departments in the midst of all this because it's not just patients with COVID-19 that we're seeing. I think all the hospitals in East Tennessee remain quite busy on a normal basis. So next slide, please. So then kind of what does this look like from a hospital perspective? So as we've said multiple times, space is really not an immediate concern. We all have a plan to address that. One thing we do have to keep in mind is that long-term care facilities, post-acute care facilities, their whole situation has been significantly complicated by COVID-19. And so some of the way we move patients out of the hospital, not everybody is able to go directly home. Some go to rehab, some go to other facilities. And so if that becomes more of a challenge to get those patients to those facilities because of the stress they're experiencing, then things can back up. The second bullet, we've said it many times that staffing is the focus. And I just want to kind of make the point that reducing elective services does not always help the situation if you're focused on staff. And the simple reality is that not all staff are trained to do the same things. They don't all have the same training and skill set. So if you ever contemplate a reduction of an elective service, and that has not happened here in our region yet, but if you contemplate that, then you need to determine if you're doing it from a staffing acquisition standpoint, you have to ask yourself if the staff you're acquiring actually meet the clinical need where you need to apply it. And so I don't want everybody to have the impression of, oh, we can just stop doing a bunch of things and gain a lot of staff. You got to gain the right staff for the right situation. There are other staffing concerns, just the staff with COVID-19 really not an issue that we see very much at all contracting in the hospital setting, but just in the outside of the hospital in their personal lives, and then the effects that have been on childcare. Then just to even take it further, and these are very much hypotheticals, guys, but I think there's enough confusion about that, is that if a surge really continues to worsen, then you can start to look at the caregiver to patient ratio would be one thing you could look at, is that these patients have to be taken care of in some way. If you've already had to reduce some sort of elective services, then what would you do next? You look at those ratios. And then ultimately, although the beds and ventilators and things like that are certainly not the focus on the front end, resources could become strained. And earlier this week, I was actually surprised to be reading about, I believe it was Utah, where there were some of the healthcare professionals and the governor were talking about this, that there was concern that could really be a reality in the state of Utah. We have some of these states, Utah, North Dakota, there are a few other states in that region that are really seeing aggressive spikes right now. So next slide, please. So this was Vanderbilt shared this. This is not the first time that they brought it up, and I believe it was mentioned in this meeting several meetings ago, but they've updated it. And this is where Vanderbilt has done a study really tying mask, and not just mask, but some of the other kind of public health interventions to hospitalizations. And what they essentially have done is they set a baseline of July 1st, and they looked at growth in hospitalizations and they stratified hospitals in 4 categories: those that have less than 25% of their patients in counties with a mask requirement, 26 to 50 of their patients live in counties with a mask requirement, 51 to 75, and greater than 75%. And you see that there is obviously much more significant growth on the top in terms of, on a percentage basis, hospitalization growth than those on the bottom. And so as we get some survey data, the Tennessee Hospital Association talked about some survey information that of those people who really are not bought into masks, there's still that significant percentage that would say the reason not is just that they don't believe that they work. And so the more data that we can show that suggests that they do have an impact on, if you don't want to get at a microbiologic level, just look at an outcome, look at something like hospitalizations, which is what Vanderbilt's tried to do here. Next slide, please. And so then to wrap up, just our key data points. So October is already the worst month of the pandemic, and it really does set the stage for November. We do see that more of those cases are consistently increased number of cases in the 51 and older age demographic. And then the hospitals are, I'm not referring just to our region, but we're hearing across the state, hospitals feeling the impacts of COVID-19 on operations. And there's nothing from a societal standpoint to make us think that there's such good news on the horizon that won't continue on into November. And so, Dr. Gocher, I believe that prepares this portion of my prepared comments. I'll be happy to take any questions. And again, I'll say that, again, we said we were yellow, and we haven't adopted a stratified system, but we called it a yellow worsening at this point.
Thank you, Dr. Shamiya. Questions, comments from the board? Dr. Shamiya, I may have missed it. Did you in the past have had that number of hospitalizations per case? We were in the low 40s, went to the high 30s. Is that holding at about the same level?
Yeah, we have, we actually, just because it wasn't changing, we haven't, that has not been shown to me in several weeks. I certainly can double back around to see where we are in terms of the relationship between cases and hospitalizations. And I'll be happy to bring that back next time. Your
recollection is that it's holding pretty much between the high 30s and the low 40s in terms of hospitalizations per 1,000 diagnoses.
Yeah, that is the last time we looked at it, it had started in the high 40s per 1,000 and had slowly dropped to I believe it was the low 40s. That is my recollection.
Thank you.
Yes.
Any other questions or comments? If not, again, thank you for a very thorough report. And next item on our agenda, number 9, are the educational institution presentations. So I want to start with the University of Tennessee, and I see Dr. Plowman is on the line with us. Dr. Plowman, do you have a report for us this evening?
I do, and I don't know if someone can start my video. I can't control it here. Okay, there we go. Well, thank you all very much. Thanks for having me. That was super informative, both of those presentations we just heard. I'm so appreciative of the partnership together with the hospitals in town, with the county health board, all of what you all are doing. And I am grateful for the opportunity to be able to share with you all tonight where we are. I want to start with our most recent case count data. And I really want you to look at this graph for a minute, because this tells our whole story in a way. We started bringing students back to campus on August 9th. On August 19th, classes started. So we gave ourselves 10 days to move students in gradually. And you see what began to happen. As we brought students back into communal living, they're moving into the dorms or Greek houses or into their apartments in the community. The month of September is when we had the huge spike. All of those cases just about are attributable to students. Those two lines get merged together there. Dr. Burks was here on September 15th. And the next day after her visit, you all implemented some restrictions about selling alcohol after late at night to help us with the bars, with the size of gatherings. You see our numbers began to come down. We put in place some restrictions right around that time on campus that we now have begun to lift a little bit. The restrictions on, they can now dine in, but they still have to be socially distanced. And so our numbers have steadily now stayed flat. So we're really happy with this. As of today, October 28th, we have 60 active cases. So that's down from at one point, we were about 682, I believe. 51 students and 9 employees. We still have yet to trace any transmission of the virus to the classroom, to the lab, to the workplace. On the next slide, you'll see again, we reported the lines mirror what I just showed you, the number of new cases each day. On the next slide, you'll see our isolation and quarantine numbers. What you see during that peak is we had a lot of pressure on the system for the 2 types of spaces: quarantining for students who are close contacts and isolation for those who've tested positive. And you see where we are right now. We have 304 people in self-isolation or quarantine together. 89 of those are on campus, 178 off campus of the students, and 37 employees. So let's go to the next slide. We have been doing this community saliva testing, and we started it at the end of September. We have really gotten this down operationally. We will be doing this. Every student will be tested in the pooled saliva every week. So let me just walk you across this slide. Look at the first 2 dorms reflected here are Dogwood and Magnolia. We had an 80% participation rate. Students are required to do it. It's hard to get them all in there, and there are specific reasons why some of them aren't in there. Some have gone home to quarantine. Some have already had it. We took 531 samples of pooled saliva. The typical pool size for that sample was 3. So it created 179 pools. We showed 2 pools that were positive. Of those, 6 individuals were identified and referred to diagnostic testing. 1 of them reported positive. So what we have been really happy to see is that where we are right now, our overall, the positivity rate from this, and this is for just on-campus housing. And as of Monday, we completed the last dorm. So we've done all the Greek houses now and all the dorms, and the positivity rate maintains at about less than 1%. So that gives you that is our story for this fall. I want to say that I think our campus has learned how to live with this to some degree. We're going to be doing much more testing. We're going to rely heavily on pooled saliva. We use the PCR testing for students with symptoms, employees with symptoms. We do PCR testing of a lot of frontline workers in facilities. We are going to be offering that to, we offer it now, but not a lot take advantage of it. Any employee in the spring, and students will be tested, as I said, those living on campus every week. We're also going to make it a requirement. We're going to ask students to opt in, encourage them, off-campus students. If you're coming to campus for any reason in the spring, for class, for going to the TREC Center, for going to the Union, we want them in our testing program. And so we will be standing that up in the spring. I want to say that I read an article last week where Dr. Burks was quoted after she's gone to 29 universities, what she's seen. And she was so positive in saying that what you see among college students, they're changing their behavior. They are adapting to this. They're wearing the mask. I taught a class this fall. I have not one time, face-to-face, not one time had to ask a student to put the mask on. Just yesterday, we had a little tension early on with parties off campus. They're still happening, but I think They're not as sizable as they once were, and we've gotten all of the fraternities have come together and they issued a statement just this week. All the presidents have signed a pledge to lead the fight against this spread of COVID on our campus. And it requires the fraternities to follow all the guidelines for social gatherings on and off campus. They did this on their own. And I just wanted to share that as an indication, I think, that we're adapting and we're making tremendous progress. Now, our classes will be completed, the face-to-face version, by November 22nd, and students will be leaving and going back home. We will be encouraging every student to get tested a few days before they return home, and we will be educating them on what they need to do once they've had the test, which is quarantine themselves until they know the results, and then make decisions about what they do for Thanksgiving and going home accordingly. So we are, at this moment in time, we're much happier with where we are today than where we were in the middle of September. As we bring students back, we've delayed the return to campus until January 20th is when classes start. Again, we will still be in some classes online, some hybrid, some face-to-face when they return. And we hope to have another semester that's successful. It's not the semester anybody wanted, but none of us are living the lives that we wanted right now. So I'm really proud of everyone at the university. And I just feel like knocking on wood as I talk about this, because, anything could happen tomorrow or the next day. So thank you for letting me share that with you all.
Thank you very much. Any questions or comments for Dr. Plowman on UT's information this week?
So Dr. Gocher, I had one question, maybe for Dr. Plowman or maybe for Dr. Buchanan, but just if you have 18 positive pools of however 60, 70 people in those pools, I would think then you have to have at least 18 positives. So how do you have more positive pools than actual positive tests out of those pools?
Because each pool, it just tells you whether there's a positive case in a pool. Okay, so when it says individual samples so out of the positive pools could have been, in that case, it would have been 6. Typically the pool size was 3 and there were 2 positive pools. So that's 6 students. That's 6 individuals. Does that make sense? So the typical pool size, sometimes the pool size was 4 or 5. Are you following that?
I think so. Yeah. I'm good. Yeah. Thank you.
Wrap your head around the pooled saliva. There's 3, 4, or 5 people in each pool. And what we will know is that in so many pools, there's sign of the virus. We don't know if it's one person or all 3 or all 4 or all 5.
Okay. Okay. Thank you.
I love people checking on my math because it always needs to be checked. Thank you.
Yeah. Thank you.
Thank you very much. Next on our educational institution presentations will be the Knox County School System. And Ms. Wagner, if you have a report for us, please.
Yes, sir.
Thank you.
Okay, next slide, please. So as of October the 27th, we have 45 students that are active cases, 27 staff, and which makes a total of 72. Next slide, please. Okay. This is a graph from October the 19th through October the 27th, and it just shows right before the active students are the light blue and the active staff are the dark blue. Next slide, please. The number of students that have recovered is 317, and the number of staff is 183, which totals 500. Next slide. This is the number of recovered cases as well through the week of October the 19th through October the 27th. And this is just a different way to look at it. Next slide. The number of students in isolation is 794 or quarantine. The number of staff in isolation or quarantine is 115. The total in isolation or quarantine is 909. Next slide. This is for the week of October the 19th through October the 27th for the number of staff and students in isolation or quarantine. That's just a different way of looking at it, bar graph. Next slide. Okay, these are the COVID metrics, and for October the 27th, student attendance, teacher and staff attendance, bus service, and cafeteria are all green, which means go. That's a good thing. And then the custodial support staff is yellow, and the substitute availability remains red. Next slide. This is the Knox County Schools daily COVID metrics, and the green, yellow, and red, and it just gives a better explanation of what each section means. Next slide, please. So the KCS metrics for substitutes. The substitute metric was yellow 4 out of 5 days last week. Teachers are allowed to teach remotely while in quarantine or isolation, which has created additional demand for subs. We're doing our best to provide coverage to allow for the preservation of staff members' sick days and provide continuity in the delivery of instructions for our students. So the green fill rate was greater than 75%. The yellow fill rate was between 70 and 75%, and the red fill rate was less than 70%. I think that's the end of my presentation. I'll take any questions if you have them.
Thank you, Ms. Wagner. I have just a quick question. When we look at substitute metrics, it looks like this is one that's been most troublesome. And I think maybe a few meetings ago, when we asked the question of how that can be improved, and I was just trying to recruit more substitute teachers. In that red zone, we have a fill rate of less than 70%. Do you have a figure for exactly what that is? Is it 65 or 50 or 40 or what is that?
I don't have an exact figure, but I can have that for you next week.
Okay. Okay.
I sure can.
I'm just curious how close we are to at least going to the next level.
Okay. I will have that for you.
I also have just a quick question. I think it would be useful, Lisa, to know what's your usual fill rate?
Okay.
You know, I mean, you have a historical data of what your historical fill rate is. But also, while I have the floor, I will say that Lisa and her staff and the principals and coaches at the schools have really been very diligent. And it's taken a while to kind of work some of the kinks out and figure out how to do things, but they're being very diligent about when to raise their hand and say, you know, question what they need to be doing, and very diligent about following our guidance. So we really appreciate that partnership and the concern that they're showing for the students in the community.
We appreciate our partnership with you too, Dr. Buchanan, and all your staff. We couldn't do it without you. So thank you very much.
Thanks again for that report. Are there any other questions or comments on Ms. Wagner's report from Knox County Schools?
Dr. Gocher, this is James Shamia. I had 2 questions, and it's probably for both Ms. Wagner and Dr. Buchanan. And their question, I've heard them both more than once, but I have to say they weren't necessarily specific to Knox County schools. They may be broader, just schools in general, but I'm interested in their input. One is what I call the contact of a contact phenomenon. And so I've heard situations where a student was positive, and it may be that a circle of other contacts are sent home. It might even be a whole class that's sent home. But you know, some of those are clearly higher risk than others. But then the parents of those students who were contacts are also told to quarantine, which and again, that may be people who misunderstood, or those may be one-offs that may not have been Knox County, but I just wanted to get a sense of whether that is what folks are being told, or what is the expectation for the parents of that student who's sent home. Again, the student doesn't have COVID-19. The student was 4 desks over, let's say, from a student who did have COVID-19. What are those parents being told? I know the student, they have to quarantine at home, but what are the parents being told to do?
The parents don't have to quarantine.
Right.
We don't quarantine contacts of contacts. We don't ask them to stay home. I mean, at least no one in our group has.
Okay. And again, what the stories I heard, I'm not saying they were specifically Knox County. I've just heard that more than once. And so I wanted to get clarity. Then the other question I had is, as we move toward, this is truly from a public health lens, as we think about breaks, Thanksgiving break, Christmas break. So if a student is positive 2 days after, 1 day after they all go home for Christmas, whose responsibility is it at that point for that last week of school to go back and make sure that, oh, these people all need to be contacted? Does that still on the school, or does it all fall to the health department?
No, that falls on the school.
Okay.
Oftentimes,
But we would do it together.
yes.
We work through fall break and all of that stuff. We will cooperate and do that together.
And Dr. Shamia, this is Charity Menifee. I wanted to say one where you might have heard the stories about the parents of contacts. If the child that's the contact is at home and becomes symptomatic,
Sure.
then obviously they have to. So sometimes people get confused with that. So they then become a probable case, which gets treated like a case, and then their family would have to quarantine.
Okay. All right. Thank you. I still think there's a lot of, we all know this is complicated, but I still think there's a lot of confusion despite everybody's best efforts to educate. So thank you guys.
Yeah, and we can certainly remind, Lisa can remind her staff and remind our staff about that. I know we get a lot of questions about contacts of contacts, and contact of a contact is just a person.
Yeah, that's right. Or yeah, I have a different way of saying it, but same end result.
Any other questions for either Dr. Plowman or Ms. Wagner? If not, thank you all for your reports, always timely. And we'll go to the next item on the agenda, which is feasibility of additional restrictions. Dr. Shamia.
So thank you. So I have just a few wordy slides on this one. And honestly, I submitted this to the agenda well over a week ago, and I would have retitled it if I had redone it. It's really just, we're just minutes away from having what is probably the wrapping up discussion about these more refined metrics. And then we're also then potentially 30 minutes away from maybe even using those metrics. And so before we got into the very specifics of the cutoffs and numbers, I wanted to continue the conversation, or at least set the stage to potentially continue the conversation that we ended the last meeting with, which is, I just want to make sure we have an understanding of the role of these enhanced metrics before we actually approve them. And at least that's my intent. And so these slides are purely to be conversation starter in this, and hopefully we can have some interaction. So next slide, please. And this will only take a few minutes. So this is one sense of what are all the factors coming up in the next several months. Well, we know we have flu season. We don't really have any idea just whether it's going to be a light flu season, a significant flu season. We know that there's, the Thanksgiving and December religious holidays with travel and social gatherings, and the fact that it may be difficult for people to despite every recommendation, those are going to be tough. We have university students going home with travel. Colder weather, I think that has two factors. There's going to be more people indoors without question. And it's also going to be, there's at least some thought out there that cold weather may have an impact on accelerating virus spread. And then, of course, we don't know what this regulatory policy political environment we're in. We don't know how that may change. And so, as I mentioned earlier, hospitalizations seem to go up much faster than they come down. And so we may kind of stack spikes on top of each other where a spike occurs before the last one was able to recover. And so we may have a census that continues to rise into January. That's at least a possibility here. It's not a certainty, but it's a possibility. Next slide, please. And so then thinking about what the population may do completely on its own. And we had some very interesting survey data about that. There's a significant amount of the population that wants businesses to, for example, have their employees mask and to require mask. We do know that mask usage in Knox County seems to be fairly good, but surrounding counties are varying in that. I do sense that when people are personally impacted, without any sort of additional policy, if it really impacts them or someone they know, then that may affect behavior. But my concern in that is just it's going to have to impact a lot of the population for that to really have enough of an impact to, in and of itself, slow down the case rate increases. And then certainly, as if the hospitals get strained, that would send a message as well. And I know the hospital systems this week sent a joint press release, really not, I mean, just saying, yes, they're seeing more COVID-19. We're seeing an increase in hospitalizations, and we really want everyone to get their flu vaccine, and we want everyone to mask when able. Those types of positive messages we tried to get across. Next slide, please. So I'm not going to go through this again. It's just, this is what I just went through about that there are a variety of factors that may impact the hospital. And so the hospitalization, hospital capacity may or may not become a more significant part of the COVID-19 narrative between now and February. So yeah, next slide, please. And I'm just about done. So the issue is that, I mean, we're very much more a regional issue at this point. So we're the Knox County Board of Health, but this is very much becoming more and more of a regional issue. And quite frankly, as I said earlier, it seems like more and more of a statewide issue. The mask requirement stands out as being effective and necessary. And I'm not intending to get ahead of ourselves on talking about these regulations, because only in that the metrics may affect them, but the alcohol curfew or the restaurant closure, it should say, is really more of when a large segment of the population is frequenting establishments. Social gathering restrictions, just a gathering size of 25. It's unclear to what extent those will be followed. And the idea of state level policies, that doing something at a state level may be simpler and more effective, but again, that is not within our sphere of influence or control. Next slide, please. And so really, and this is my final slide, is that if at the 5% or 3% de-escalation cutoffs, we're not likely to reach any of those anytime soon. And then the idea of de-escalating and then escalating is probably not very palatable. We know that there was the public request for clarity to formalize the metrics. And I'm very pleased that those are on the benchmark website. I mean, we're now very much talking the same language as far as positivity rate and case rates per 100,000 that are spoken across the country. And so we can put ourselves in the context of other cities and other regions. But I just really wanted us to have a clear understanding as we go into this next discussion. Are these going to be just additional but more concrete things that can guide our decisions, both for de-escalation and escalation? And really, what does escalation even look like? Because if we set an escalation metric, it implies that there is an escalation in Knox County specifically. And so, I mean, this is a difficult set of topics, but at the same time, what I didn't want to do is us to set a situation where we're effectively, we set the stage for us to talk out of both sides of our mouth. So I believe that's the end of the presentation. And Dr. Gocher really just wanted to have a clear understanding of this before we just set the metrics.
Good presentation. Thank you, Dr. Shamia. Any initial discussion about these challenges or about the concept of escalation and de-escalation? If not, I have a question. It's whether there is data based on any prior information from other parts of the country, other countries, as to what de-escalation or escalation, let's say de-escalation is hopefully, as de-escalation occurs, what do we expect? Do we see resurgence? Do we see mini resurgence? Because I think we would need to know the implications. We have some numbers that seem to make sense, but what would be the epidemiologic implications of loosening restrictions? Common sense would say you'd probably get more cases. Is there a number below which that probably would not happen? Is there any information, historical or otherwise, to sort of back that up?
So I'll take a stab at that first time. So what we know from across our state and other places is that those places that have de-escalated have had to go back and escalate, taking away mask mandates, putting mask mandates back. I heard a report recently, and I can't remember where it was, where an example of a place that left regulations in place for a very long time and really truly waited until their cases were going down and reaching those levels that we see that are far away for us. So I think de-escalation, if it's going to be successful, has to be something realistically far away, because we really need to see our numbers coming down into those areas. And we look at those now and go, there's no way we'll get there. Well, we were there in March. We could get there. We will eventually get there again. I think vaccine plays a role in that, vaccine availability and vaccine when we get a vaccine. But I think what we've seen for the most part, but places that de-escalate have had to back up and put things in place again. And that's extremely painful. I mean, that's where we are considering now, where we are. Our cases are going up, our hospitalizations are going up. What can we do that might impact those that's also palatable to our community? So I don't know if anybody else has any other reports on de-escalation, but at least 3 counties in Tennessee have lifted mask mandates and put them back.
Sorry, do our state epidemiologists look at information? I would assume they do look at information from other states that have completely different trajectories in terms of maintaining restrictions and releasing them. And one example I would give would be the state of Texas, where bar restrictions were in place for a long, long time and only recently rescinded. They were in place for months. I want to say from March until a couple of weeks ago, probably, and they were rescinded. And I'm just wondering if we have those experiments out there that we can look at and sort of see what might be happening, or if there's any relevance to that at all.
We can certainly ask. There was that one report, the MMWR, that Dr. Souza shared 2 weeks ago, where Arizona had seen a spike. They put things in place and you could see stepwise going down. So we have seen that. And then I think if you look at Nashville, Nashville still has a lot of regulations in place. They still have very restricted activity and a lot of regulations in place, but they're seeing an increase now in their cases. So it's kind of gone both ways. We can ask, because they certainly talk to the CDC and others across the country more often than we do. And that was something I was hoping they would add to that White House report, because it sounded like Dr. I can't think of her name, Burt's was going to, they were going to try to add some practical lessons learned in there, but I haven't really seen that happen. Is that would be really helpful in places where they've done it and been successful, or tried it and it didn't work. I mean, either one that's useful to say this is a good idea or this is a bad idea. And so, you know, we just haven't been there. And even other countries where they've relaxed things, they've seen cases go back up. I mean, the places where cases haven't gone back up, they've kept things in place for a very long time until they truly see all of their indicators going down. And then they lift them. Now, I don't know what the metrics were they used, but that's what you've seen. Right. That's my 2 cents.
Thank you. Thanks, Dr. Buchanan. Any other comments or questions?
So, Dr. Gocher, one additional thing I'd add is that I think we need to decide how much these are guidance versus absolute. And I understand from several weeks ago the desire that the more numerical our criteria can be, the better. But I can speak from the hospital perspective that it's been very hard for us to manage around very set numbers. And so, for example, early on we'd say, okay, when our COVID census gets to, you know, whatever number, we're going to do this. Well, when you get to that number, you don't know all the situation that you're going to be dealing with at that precise moment. So even when we would try to do that, we'd get to that number and say, whoa, wait a minute, now we got to rethink this, because what we thought we were going to be looking at when we at this particular number is not what we were looking at. So I think there's really 2 layers to this. One is, how are these going to be used in a global sense? Are we really going to use them as additional information? Are we going to try to maybe use them as the predominant information and then complement them with the other benchmarks, or is it going to be absolute? And then the second thing is really at a broader sense is, you know, I mean, de-escalation right now is pretty straightforward because we know what we have in place. Escalation is a lot more complicated. And to your point, Dr. Gocher, I mean, some of that is what's our end goal? I mean, we had a lot of the conversation in the last meeting about 3% versus 5%. And, you know, whether obviously if you want better pandemic control, 3% is a better number. And so in the same way, escalating is, if you are only escalating to prevent a catastrophe, you're going to set that number higher than if you're escalating just to try to achieve better pandemic control. And so I know this is complicated, and we may not be able to really get clarity, but it's hard to make those next decisions unless we have this conversation.
I would say, you know, looking at the data and the situation, I don't think we can have having an absolute number is very challenging. I think that there's so much contextual information there that, just like you said, when you got to that number, you're like, wait, this doesn't look like what we thought it would look like. And we have to look at the entire community. And I think we're going to have to use, and I know everybody wants us to be able to say, you know, when we get here, we're going to flip the switch and turn everything off. Or when we get here, we're going to put some more stuff in place. But it's not that simple. It's not that straightforward. And I think we're setting ourselves up for, I don't know if it's failure, but I don't know, to not be true to what we've set. If we set an absolute, I don't think it would be hard for us to be true to that if we get there and go, wait a minute, this is not what we thought it was going to look like. And that's not the right next choice for us. That's not the right best thing for our community to make a difference. And I think, you know, honestly, I would hope that we're using these metrics to not avoid a catastrophe, but to keep things at a more level place. I think if we're using them to avoid a catastrophe, that is different, but I'm not sure, you know, do we want to get on the edge of catastrophe and put something in place hoping it'll stop us from going over that edge? Love to hear from the others.
Other comments, questions, concerns?
This is Maria Hurt. I would just like to say from for anyone listening, from a practical everyday to day experience from someone who's been a staff nurse in the hospital, anticipating flu season. So the reality is, in terms of why staffing is such a challenge for hospitals. Well, first of all, nurses make up the bulk of staff in hospitals. In preparation for flu season, all nursing staff are required, like we're not allowed to take vacation generally from anywhere from mid to late October through March. This is just an anticipation, because what we know just with flu season, generally speaking, our census is going to go up, acuity of patients, and in other words, how ill people are, that's going to go up. And staff themselves are going to get ill. So we all kind of have to make a pinky promise in a way, like we're not going to go on vacation and we're going to show up for work. We might be required to work weekends, overtime, etc. Knowing also that if we hit surge capacity with just flu season, we're going to be called to work in other, just as Dr. Shamia mentioned, we're going to be called to work in other areas of the hospital where we may or may not feel entirely comfortable. We may be cross-trained, et cetera. But it not only creates a logistical challenge, but it creates a profound stress, not only on the system, but a psychological stress on staff. So all of those things are going on and in place as the hospital as a system, whatever hospital it is trying to give patients the same level of care that they always have, even though census is up and staffing may be down. So I just thought I would offer a little window into the reality of what that looks like when we're talking about trying to preserve the function of the healthcare system. That's kind of the trickle down effect.
Dr. Gocher, another aspect of this that we need to look at, and it's just been brought up, is really hard, fast numbers are difficult to live by, both up and down, escalating, de-escalating. So I think we understand that, but the biggest thing we need to work with right now is, I think, education, getting the word out that our 5 core actions really can make a difference, not only in Knox County, but in the area around us. And that those counties that touch us, that do business with us every day, the people that live in Granger, Union, Loudoun, et cetera, all move in and out of our county. We need to work on education to increase the numbers of people with the 5 core actions. That's probably our best bet going forward. It's going to be tough to do onerous actions where you close down again or do other things that people will just be up in arms with. Instead, working toward an educational way of dealing with this and getting people to truly understand where we need to go and get those mask numbers up, get the social distancing numbers up, to cut down on these private social gatherings. That's what's getting us and everybody else around us. I do travel in the counties around us. I live next to one. I go up to another county on a regular basis. Very few people wear masks. Very few. So we need to encourage that. We need to do what we can to get that word out. Otherwise, we get to these escalation and we try to come up with some sort of plan to, close things down. It could very well backfire. So we really need to work on that aspect of things.
So Dr. O'Brien, a question regarding that. From a practical standpoint, how is that message brought to regional to the region, to other counties? Is it done through their health departments? Is it done through the mayor? Is it done through county government? And there are challenges to each one of those. I know some of the folks that are on, for example, Sevier County's health department, and even in the midst of this pandemic, because they were advisory only, they meet about once a year.
Yeah, there are various groups that do meet. We have an EMS Directors Association that meets. So that's one governmental group that does some healthcare, covers 16 counties. I would think that the county mayors get together or have meetings and to try to get that word out. Working with the various health departments, both ours and the East Tennessee Regional Health Department. Just an example, I looked just while we were sitting here, how many people were watching what we were doing on various venues. We had, I think it was 22 people on Facebook and 124 on YouTube while we're actually talking. So not many people are watching this real time, but they're going to be getting it asynchronously. They're going to get it through social media, et cetera. So we need to look at ways that we can impact this pandemic other than these meetings live and getting out there and working with others. It may require us to do some things that are a little bit more innovative, with Twitter, with Facebook, with Snapchat, whatever, to get that word out more than what our health department is doing, more than what East Tennessee Regional Health Department is doing. And I'm not sure what the answer is, but we need everybody to buy in, and we need to find different ways to engage. And obviously what we're doing right here live is only engaging a very small number of people. And we'll get to the discussion probably later that relates to what's going on the policy and legal aspects, Knox County Commission, other things going on, that we need to interact together to come to some common foundation, some common ground, that we're in this together, that we're not fighting with the commission, with the mayor, with whatever. We're working together, and that we offer ourselves to work together. So I'll just throw that out. I'm not sure how we're going to do it, but I think we're going to have to work that way.
So,
Go ahead, Dr. Schmidt.
but I was just going to, Dr. Gocher, thank you, Dr. Buchanan. Actually, I think this is a great line of discussion. And item 15, which was something I'd put on the agenda, was really kind of setting the stage for this discussion about how do we get out there and engage in the community and whatnot. And so, I mean, obviously those things are linked together because, it's the back and forth between, are you going to do regulations? Are you going to do education? Are you going to do some of both? But Dr. Gocher, I just wanted you to know that I've got this, I have a placeholder on the agenda for this part of the conversation later as well.
Hearing you, Dr. O'Brien, I don't know how we could work with the surrounding counties. I don't know if the healthcare systems have relationships with those. All of those county mayors have the authority to put a mask mandate in place, at least until the 30th of October, unless the mayor, no.
We hear it's going to change. This is true.
We hear it's going to extend till the end of the year that they'll have that authority, but right now it expires on the 30th of October. We're hoping that that'll be extended, but we don't know. That'll have to be an extension by the governor. So, I don't know if that's a way to work with those counties to put, two of the counties around us do have mask mandates. I think if they had mask mandates, I think it could potentially improve our regional picture and reduce cases. I've got some data from the Tennessee Department of Health, in addition to the Vanderbilt data, demonstrating how masks, they don't stop the transmission, but they certainly flatten it and slow it. And if we could, how can we get that in a more regional picture? And I don't know the answer to that. I think the other thing again, going back to not using hard and fast numbers, if we have a spike in long-term care, which could happen, other places have had that happen, or if we have a spike in one cluster, a large manufacturing company or something like that, we don't need to make a change in what we're doing based on that, because that's not the general population. So I think we do, I hear that we all want metrics, and it'd be great to be able to say, that we have set metrics, but I don't know that we can come to metrics that are just, single item metrics that we can just hang our hat on, because it's too complicated. And I'll be honest, when I look at our numbers, the pure public health in me says we need to be shutting things down. But the practical side of me that's practiced and lived in this county for a long time knows that that's not going to be tolerated, that more closures are not going to be tolerated by our community. And that's an important piece. I think there's an economic impact to closures, but there's also just that social impact and that, people tolerating them and the, is it just, I mean, there's already a lot of tension and a lot of frustration and fatigue. And I think we just add to that. And I'm, just don't see that as our role to add to that. I don't, I'm not sure when we would be able to do that. I think it's going to have to impact a lot more people's lives before they're going to say, yeah, okay, we can tolerate some changes. I mean, right now, what we know is the majority of people do support the mask mandate, and business owners, most of them support the mask mandate. And how do we get that more widespread in our region? I don't know the answer to that. We've got a lot of factors coming into play. How do we get even more widespread adoption of the mask mandate in Knox County? We've chosen to take a non-authoritarian approach to encouraging folks to comply. I don't see us changing that. I don't think that's appropriate. So I'm not sure that would, I don't even think it would be helpful. I think it just would increase the pushback and increase the frustration and anxiety among people who don't agree with it. And even among probably some people who do agree with it. So I know this hasn't answered any of your questions, Dr. Shamia, because I don't think there's an easy answer to when we did talk a little bit about, basically what I would see is if we would kind of take things away in what went on last would come off first, and mask mandate, which has been in place for a long time, is going to stay in place for a while because we really need to see our numbers significantly change. That's the easy, effective thing that we have in place. When we get down to talking about the mask mandate, I'll pull up the data to show you what the Tennessee Department of Health has seen when you have a mask mandate versus you don't have a mask mandate.
So I think this has been helpful, Dr. Gocher, because I think we go into the next conversation with, first of all, just having had this conversation, but also some more clarity on the idea that these very well may not be absolute. They're additional information. At least that's of the people who spoke. That was seemed to be the sense of the consensus.
I agree. I just didn't weigh in. Figured I wouldn't say the same thing.
Other comments, questions about Dr. Shamia's presentation? If not, again, thank you for that presentation, and we can go to the next item, which is a segue in, I think, very appropriately, and that's finalization of potential metrics. Dr. Buchanan, if you'll lead the discussion in that, please.
All right. So what happened between last meeting and this meeting is that my epidemiologist and the data analysis at UT Medical Center got together and talked about our input from the last meeting. And what you're going to see is the updated version of the proposed metrics for COVID-19. So next slide, please. So here are our current policies in place.
Sorry.
Oops. That's okay. We have three, as we all know, the mask requirement, social gathering limits, and the alcohol. Actually, we need to probably change that one from alcohol establishment to
Yes.
Something different. But anyway, we have the curfew in place. Next slide, please. So, and I got these right before we came in here. Now I can't. Give me a moment to come up to speed. So you'll notice that last time we had positivity rate, and testing volume. I thought they were going to be together.
They are you'll see it in a minute.
Okay. So
But they changed the number, I think, to
okay.
5%.
So the positivity rate now is 5% as reflected from our previous discussions, and then greater than 10%. And the new case is 5 per 100,000 and 10 per 100. And you'll notice, so this right now we're in the 20s per 100,000. So, we're twice what we would say for escalation. And then the Hertz data and policy change. Okay, so keep going. I'm sorry. Again, I should have looked at these. So testing volume, so recession barrier would be more than 1,700, but that's definitely, we're not near there. We're above the escalation volume for testing, but we're not at the recession barrier for testing right now.
And I think that's what this is Charity Menifee. I think that's what you discussed last time, right?
Yes.
This is the same.
Yes. So here are the new cases. Again, as we reported previously, we are definitely not at the recession barrier for new cases, because we're still seeing about 100+ cases per day.
This was the previous data, by the way.
Yeah, this is the previous data, so I'm a little sorry. I'm struggling with this. Do you
Sorry, yeah, this is
Go
Charity, and so this is what you guys discussed previously. So last meeting, 50 patients average, most recent day, an escalation of 100, and this is where they went back and had the discussion of how to better represent the flexibility that is needed for the hospitals. And Dr. Shamiya might have been updated on this and be able to jump in as well. But basically looking at a zone of bed occupancy for those new patients to give us some flexibility again for the times that there are, if it's higher acuity patients versus low acuity patients, and what the other census is, and what their staffing ability is, and all of those things. So this was the kind of the thresholds that they were looking at. So we've got the COVID beds, the non-COVID beds, and the percent of COVID-19 beds. And we were looking at ranges for those. Is where we settled there. Dr. Shamiya, do you have anything to add on that one? Because there was a lot of discussion back and forth there.
Yeah, and I may be a little bit.
I gotta bring up my notes too.
This is James Shamiya, so I may be a little bit kind of confused, but I can tell you this, is that after the last meeting, I presented what we were doing here conceptually to all of our hospital partners on one of our Wednesday calls, the idea of set numbers versus, remember at the last meeting, I talked about stratifying yellow because it's so nuanced and it could be related to staff. It could be related to a variety of other issues. It's that complex relationship between COVID-19 census and non-COVID-19 census. And the unanimous thought of the group was that we really want to stay with red, yellow, and green, but make yellow improving, yellow worsening, and yellow stable. And as I said today, we were yellow worsening. I know that's not a number, but I mean, we spend significant time once a week discussing what that should be. And because it really is what is we have the finger on the pulse of what is exactly our local situation. So this is what I'm seeing here would be taking it in a different direction than what we had discussed. Is anybody there?
We're here. Any other discussion?
Yes.
You're
Yeah,
muted.
sorry, I was
Charity
talking.
was talking. You're muted. Sorry.
This is Charity Menifee. The Dr. Shamiya, that still would sit there and be that way. So those are the benchmarks, and I think the intent was to kind of have both be an overlay. So I pulled up my notes in more detail. So what this is looking at is, so on the left vertical axis is your total beds, and the the right vertical axis is the percent of beds occupied by those COVID patients. And so this was allowing the discussion today on this. And again, this was they've been working on this off and on through everything over the past couple of weeks, and definitely this week. Basically, this one doesn't lock us into an absolute volume in the way that we had previously discussed using it. And that this allows the hospitals to be able to flex logistically to accommodate more patients and that way they can have the means to get back out of, back to yellow from red, given all of their surge plans and all of the things that go in there. It also allows for, some variability with testing availability, and then the things that we just don't know. So if COVID volume in the hospitals goes up, and by that nature, COVID burden in the community is going to be up, how does that impact the fear of people from utilizing the hospitals? And what, we don't want that to happen. But how does that play into it? So all of those things, I think this is where Roberta and Keith got to in having ranges for, again, the percent of bed occupancy based on our Hertz data, and along with knowing the benchmarks are there too. And this was in the concept of not having the mindset of trying to avoid having one sole metric, one sole line of, 200 beds in the region or something along those lines, that there's so many variables that affect that. I hope that makes some sense. This one was extra complicated today, and I could try to get Bert online if I need to, if I'm not making that clear.
Well, I got to say, as the hospital representative, I'm not sure that I exactly know what to, just seeing this, know what to do with this. And so I can say that, I know we've essentially said that none of these are going to be set in stone, but I explicitly talked about this concept with our hospital partners, and we were, as I said, unanimously comfortable with trying to further stratify yellow. But I would have to literally understand this, take this back to them, and understand what this means before I could, on this one, I'm not just representing me as a member of the Board of Health, I'm representing all the hospital systems. And so I don't mean to be, difficult on this, but I don't exactly know what to do with this.
And that's reasonable. I'm honestly, again, they've been working on this and trying to get it ready. And I don't think they thought that this was something that is going to be ready for us to approve tonight, because I think there's some processing to be done. I guess I would ask Dr. Shamia if the hospitals have an idea of what a metric would look like. Is there a way for you to come back with that for us to look at? Because the hospitals absolutely have to have input on whatever we choose for COVID hospital bed occupancy and be comfortable with it. And absolutely. So is there a way to take this back? I don't know if you need to talk to Mr. Britt, or if we need to have, we need to get Roberta and Mr. Britt on with the hospital execs to talk about benchmarking or metrics.
Well, that's what I essentially did in the last 2 weeks. And so I'm really, again, how these are going to complement each other is that if we were at 12% positivity and 25 cases per 100,000 and a yellow rising, that's going to be different than a yellow falling, and that's going to be potentially different than a red. And so it's all these taken together. But Dr. Buchanan, I'm not going to promise that in 2 weeks I'm going to come back with anything more than yellow declining, yellow stable, or yellow rising, because it's just there's so many factors. And I guess also, just so I do understand this is specific. It says percent of COVID-19 beds occupied. So this isn't total. This is literally the beds that are felt to be reserved for COVID-19 patients, or I'm not sure I totally understand.
My understanding was this is Charity Menifee, the not the designated beds, but the bodies in the beds.
So is it percent of total beds?
It's the Hertz info.
Is it percent of total beds?
Yes. Because those total bed numbers on the left are what I thought were the total beds.
Yeah, I think it's actually percent of total beds.
Yeah.
I know the slide, the title doesn't say that. But.
So guys, what I'll say is, you've got a tremendously engaged and very collaborative group of healthcare systems. And so, I don't know that this is, so it'd be different if we were checked out, but we're very engaged. And so, yellow rising means something here. And so I mean, I'm happy to bring it back at your request, but I really don't sense we're going to land in a numerical way that is going to be any better than what I just described.
And for clarity for me, when you say yellow rising, that's based on the benchmark, correct?
Right. I mean, yellow worsening. I should.
Or what, either way, yeah.
Yeah. No, it's
That's based on the benchmark.
But that's really based on the prior benchmark, which we're very much comfortable with. I mean, we now have what were about 2-second conversation many weeks ago, and have turned into very significant conversations once a week about what that should be. Where are we collectively to make sure that we send the right message to the community? And all we felt that we needed to really capture the essence of that, because it is so multifactorial. Because I mean, you could be at a certain percentage, but it's really about your staff too at that point. And so we really felt that it's so nuanced and complicated that if we stratified yellow, and I came in here discussing that every 2 weeks, and then that would capture what we need to capture.
So I guess my question back to the board, and Roberta and Keith Britt might take my head off for this, but do we feel like we need a separate set of metrics when we already have benchmarks that we've been using and we've tweaked and we've added some data to that give us a picture of whether it's getting worse or getting better or staying the same in our community? Do we really need these other data points? And I don't know the answer. That's a question for the board. Are they useful, or is it better to go back to what we have? We're using percent positivity now. We're using cases per 100,000. I know everybody wants to be able to say, we'll hit these marks and we'll go, but we've said all along, it's all of those pieces that we have to look at. Just like you have to look at all the pieces in the hospital system, we have to look at all the pieces in the community. And it's not just one piece of information that we're going to make a decision on. So do we think the metrics are helpful, or do we need to just stick with our benchmarks and look at those?
One thing we may want to do is on the hospital side, leave it as is, but we could also still look at like the 5%, 10% one, and just use those as another way, a guideline, not a hard fast. We're going to do something when we hit 10% because we're already above that, but that's just informational. It sounds like the hospital systems already have a good system, and we may want to just continue that.
Dr. Shami, I have a question for you, and this may be something that all the hospital systems may have to kind of think about this, or maybe you know the answer. And that is, if we look at these figures in the slide before us, which is green zone, yellow zone, red zone, with red zone being 12.1% COVID positive beds, and I'm assuming these are acute care ICU combination. What does that, in practical terms, what does that look like for the hospital when a hospital is at 12%? Is it bringing in extra people? Is it expanding some acute care areas to critical care areas? What does that 12% look like when a hospital population hits that versus 4% or 5% or something?
So, and this is James Shamia speaking. If I understand that, so the idea being, if a hospital was greater than 12% of its inpatient population with COVID-19, is that what you're asking?
In practical purposes, what does that look like in terms of hospital staffing, utilization of beds? How does the hospital respond? Are these hospitals capable of responding?
Yeah. And so, Dr. Gocher, your question is the exact, I'm glad you asked that, because that's the exact reason why I'll come back to the idea of that conversation and the stratification is I can't tell you until I'm in the middle of it what that looks like. Because it depends on a lot of different factors other than just that number. It could depend on is a hospital in trauma season? Is it not in trauma season? How has the flu season been? Has it been a light flu season because people are wearing masks? What is the overall hospital census at that time? And so I would say, and guys, I don't know if there are more slides to look at. I'd be more than happy for the slides to be brought down and back to us if or at least
No, that's
temporarily.
all the slides. So yeah, we can take them down.
So, I mean, guys, my personal opinion is that there is, because of the universality of looking at specifically positivity rate in cases per 100,000, those are on the website. And so I think that was already a step in the right direction. But there is probably value in looking at those so we can speak this same language as a lot of the rest of the country is and factor those into the existing benchmarks. And my recommendation, and to Dr. O'Brien's point, is that I really do like the idea of stratifying yellow into, I mean, let's face it, we were coming down for weeks, but we were still yellow because we were above where we had initially transitioned from green to yellow. So the idea of breaking yellow down says more, worsening, stable, or improving, but it's still going to be, at the end of the day, this will fall to us. And so we feel that it's that collaborative situation that we've set up that we'll have that conversation and bring that information. I know it's not a set number, but I don't want to make this too complicated. And I'm afraid the road we're on with the hospitalization numbers, even though it wouldn't be the end all be all, I'm afraid we're on that one headed down that road.
Thanks for a really good discussion on that. Any more points to consider in this section of the agenda, which is finalization of potential metrics? So
I think we've got some stuff to take back to the drawing board, because I expected something different also on the slides. And I apologize for not looking at them beforehand and having had more input on that. So what I hear y'all saying is that sounds like with the hospitalizations, we're going to kind of stick to the benchmarks and really not add some new metric to that, correct? Is that kind of a consensus?
If there is a way, either in the current benchmark structure and whatever we create to further stratify yellow, we would very much like that and support that.
I don't know that we can do that. I mean, I don't know that we the health department can do that, because we don't know what all the things you guys consider to.
Well, no, Dr. Buchanan, what I'm saying is when we have our Wednesday conversation, we will tell, in the same way we say we're yellow this week, we'll simply say we're yellow but worsening this week, but we're not at red. It'd be as simple as that. Or we're yellow and stable this week. Okay. Is that doable?
Yeah, it's doable. We'll have to look and see how we represent that on the website, if there's a way to represent that, just so people can see it, and it's not just yellow. So I don't know how we'll have to get our creative minds thinking about that.
You can just use an up arrow next to a yellow circle, or down arrow, or
yeah, our graphics people have to figure that out, because they'll figure it out. So if we take the hospital piece off of what we presented for the metrics, I'm just trying to get a sense, is the board ready to vote on that, or do we need to tweak it a little bit more and bring it back? Because I mean, obviously right now, our metrics are not getting better, and regardless of what we choose to use for metrics, our case counts are higher, our cases per 100,000 are higher, our hospitalizations are not the highest they've been, but they're high. And, so most of all our indicators except for staffing are yellow. So I'm not sure, it's certainly not a time we're going to be relaxing any guidelines. So do we feel like we need a little more refinement of those metrics to make them useful?
I think that may be a reasonable approach to especially since Dr. Shamia has said that the hospital system probably needs to look at it a little more thoroughly. That may be reasonable.
Dr. Gocher, I actually don't, I mean, guys, I'm sorry about this, but I'm not sure what I'm going to come back with that's any different.
Right.
No, right. I wasn't expecting you to take anything back to hospital systems, but I've heard a little bit about, I don't know, the other indicators. For some reason, I thought positivity rate and testing volume were somehow going to be combined. And I didn't see that in what we presented tonight. So I feel like I need to go back and talk to Roberta and just clarify where they're coming from with that particular one. I don't know. It's different. But anyway, I feel like I need to go back and have a conversation with her to understand that one. And, you know, and I think that's kind of where I am with that, is that I'm feeling like I put something out there that I hadn't fully vetted myself, and I apologize for that. I feel like I need to go back and have a conversation with her to make sure I have clarity on how we were going to use positivity rate and testing volume. And, you know, the challenge with testing, we know positivity rate and testing volume both, you know, depends on people getting tested. And so that's kind of where I am with that, because I somehow thought we were going to combine those or drop one of those or do something different. And it didn't appear that we did.
Dr. Gocher, my final comment is my recollection from the last meeting. What I recall is that we had not voted, but decided that we would probably not use testing volume. We were going to use positivity rate as the combination of cases and testing volume together. We were talking about still using cases per 100,000, and we were just going back and forth on the cutoffs. Again, depending on what is our intent, what are we trying to accomplish? And then I was going to circle around with the systems and have that conversation about how to further classify hospitalizations. I believe that's where we left it. At least that's my recollection. And so I think it's really a matter of then, and I agree with you that we probably not something that we're going to finish tonight, but I think if we can take it from there and cross the finish line with it, that's what we need to do.
We'll finally land that plane.
Yeah, and that's kind of how I remember the conversation last week as well.
Yeah, and the thing is, we're in no rush. We're in the yellow. We're not going anywhere right now. So it's okay.
I've got a question for any of the board members that may know about this, and this has to do with testing capability. The PCR is generally being used as our gold standard of testing, and usually the Panther or Panther Plus machines are being used. Do we have a sufficient number of those and a sufficient workforce to get the throughput with the machines that are in the community? Does every hospital have one?
No, Dr. Gocher, that every hospital does not have one. Every hospital has certainly made good arrangements to make sure that their testing is done, whether they have their own or they have a variety of labs. Dr. Buchanan, my understanding is that there is excess testing capacity in the community that is not being used right now. So for all those months that we talked about people not being able to get a test, there are excess tests that are not being used right now.
So
yes, true for us and others as well.
The choke point or the stumbling block is getting people to be tested, not throughput through the laboratories.
That's correct, to my understanding.
Thank you.
So we're got more to come on the metrics, and I apologize for that. We'll bring them back next time.
Thank you for a very good discussion of all that and the complexities of it, certainly. Next item on the agenda is review and discussion of our regulations. And so we'll start with the face covering regulation 2020-1. And I'll open the floor for discussion.
I think we need to keep it as is, and there's really not much discussion that we probably need to have. I think it's pretty apparent.
And we just have one piece of data to share for the public and for everybody to see, which complements what Dr. Shamia showed, the Vanderbilt information that Dr. Shamia shared. This is from the Tennessee Department of Health. and it's data on, let's let Charity pull it up. So this is coronavirus rates in counties with mask mandates. So if you notice, the dark blue line is metro counties with mask mandates. The light blue line are the non-metro counties, and then the yellow are counties without a mask mandate. And so what you see is the case rate in those counties that don't have a mask mandate is higher than the case rate where we do have mask mandates. And next slide, please. Then this is also telling the doubling rate in those same breakdown.
Notice the date, by the way. They're going to update this periodically.
Yeah, so they're going to update this periodically, but if you'll notice, so remember, a higher doubling rate is better than a lower doubling rate. And so in metros with mask mandates, the doubling rate is much higher than it is in other places in the state. So again, just affirming that masks work, that we need to keep the mask mandate in place. And if we could figure out a way to put mask mandates in the whole region, that'd be cool. But I don't think we have that authority. So that's it. I just wanted to share that. And we'll share that periodically as they update it.
Any other discussion on 2020-1?
Can I just add that I recognize that we make decisions based on hard data like that and not on people's feelings. But I really did appreciate Dr. Cahill's presentation on that highlighted that most individuals are in favor of masking, and that it really, we do have a small vocal group that have spoken out against it, but I just wanted to say that I appreciated Dr. Cahill's presentation to go along with the data that we already have.
I certainly second that opinion, Ms. Roma. Thank you. Other discussion on 2020-1? If not, we can go on to discussion of 2020-5, which is the sale and consumption of alcoholic beverage regulation, 2020-5. And I'll open the floor for discussion on that.
Just a quick update on the regulatory side. We've had very few complaints about this, and we haven't had any citations at this point. So I'm not sure the holidays is the right time to change this. So I would recommend leaving it in place.
Yeah, this is one of those things that, within most of the county and city, it's being followed. There are certain outliers. They will remain outliers. So if, we just need to realize that. But I think the majority of business owners are being supportive at this point, even though it's difficult for a handful or two handfuls of businesses in our county.
Dr. O'Brien, and to the rest of the board, first of all, I appreciate everybody's patience and me not being here last week, but I did go over in some detail the economic presentation, and I was fascinated by what I heard, as I'm sure you all were. And one of the comments was that a lot of downturns in certain businesses are driven by concern and fear from the customers, not necessarily from any regulations. And businesses that are active may see an uptick in business from people that are just completely outside of the system out of fear. So something to be said for that, I think.
Yeah, the Vanderbilt study that Dr. Shamia shared earlier has some data on economics and how even where all the mandates have been lifted in certain counties, the economic activity has not increased back to pre-COVID levels in the state of Tennessee. So I thought that was interesting too.
Questions? Any other discussion on 2020-5? If not, we'll have a review and discussion now of 2020-6, which is the social group transmission suppression or social distancing regulation. Comments, questions?
So just before we go forward, I believe both of these are set to expire at the end of the month. Is that correct?
I'm not sure.
I think I remember that's.
I'll have to look at that.
I want to say that when we passed it 2 weeks ago, that it was set to go until the end of the month.
Yes, you're right. You are correct.
Okay.
So we want to extend it for.
So we need to decide if that's, if we're going to, I don't know if we want to discuss them together or do that separately.
Probably best to discuss them separately, but for kind of clarity, maybe we should go through the discussion portion of 2020-6 and then circle around to all of these, if that's okay with the board. So if that works, we can continue that discussion, the general discussion on 2020-6, if there's any new input, information, or anything to discuss on that.
Just something to add to my recollection, at the last meeting, we discussed these in relation to the state of emergency by Governor Lee. And he did say today at his press briefing that he's planning on extending that state of emergency as well.
Ms. Roma, when he discussed that, did he indicate that that included an executive order for distance meeting, or is that come up yet? Does anybody know that's relevant to whether we're going to meet live or on Zoom for the next month?
He did say that it would also include continuing to meet virtually.
Very good. Thanks for that information. I guess that was going on about the time we were starting our meeting, actually. So yeah.
Just before.
Right. Thank you. Thanks for your vigilance and looking that up. So if there's no other discussion further on 2020-1, 2020-5, or 2020-6, first of all, I guess just a question, are they all set to expire at the same time? Or is it just one?
No, the mass mandate doesn't have a set time to expire. What we put in that is that we review it at every meeting. So okay. It doesn't have an expiration date. So I'd make a motion that we extend the 2020-5 for an additional 2 weeks.
So we have a motion. Is there a second?
I second that.
We have a motion and a second for continuation of 2020-5 discussion. Any discussion at all? Positive information from the community, negative information from the community?
The only information we've had that I've seen is that some of the businesses that have complied have had some complaint that some of their friends in the community have not, and have been taking business away from them.
Friends being competitors.
Yes, and yes, some have not lived up to the regulation out in the county, is what I've been told by some business owners that are predominantly in the city. And they have lost, they feel, some business. But again, those are outliers, I think.
Any other discussion, comments about that? So we have a motion, a second, and sensing no more discussion, we would be ready to vote. So Narda, if you will go give us a roll call on Regulation 2020-5 to be continued. We need a time limit for continuation if we've not had one. Is it another 2 weeks? Is it 4 weeks? 2 weeks.
Dr. Buchanan said 2 weeks.
2 weeks. Thank you. So the continuation will be for 2 weeks. So Narda, if you will give us a roll call vote on that, please.
Yes, this is Narda Capicelli, and we're ready to take a vote on 2020.
Dr. Gocher?
Yes.
Let me just hop in here for a second before you all vote on this for 2 weeks. Have you all set your next set of meetings, because you were about to alter your schedule in light of Veterans Day and then the Thanksgiving holiday. So you might want to take that into account before you have a meeting, have a regulation expiring in 2 weeks.
That's a very good point, Mr. Sanders. Perhaps we can postpone definitely for later in the meeting a vote on this until we figured out that schedule so we can address it in a timely fashion, won't leave it hanging.
Can we not just say until the next meeting like the other one was?
That's possible.
I
We have a
No.
time limit on it.
Rather not. Narda?
think it needs to, I think it needs to expire at a date certain, not on just at when the board, if it's going to, unless it's going to continue indefinitely. Now you can do with it the same thing you did with 2020-1 and just have it be indefinite until you cancel it. But if you're going to have it expire, you probably need to have it expire on a date certain.
So, Narda, I believe the date that is most likely for us to move that meeting to is the 10th of November. Is that correct?
That is correct.
Okay. So
This is Maria. I have a question for Mr. Sanders. This may be splitting hairs, but I'm truly trying to understand. What is the legal and or practical significance of having something just indefinite until or a definite expiration date?
I think it adds ambiguity. There's no ambiguity in saying that it's indefinite without an expiration date, but it adds ambiguity if you say it extends until the Board of Health, until there's a condition precedent, like the Board of Health is going to meet again. Well, when is the Board of Health going to meet again? People who are being regulated need to know. So right now, I'm sorry, go ahead.
I was going to say, so for all intents and purposes, there's not a problem with 2020-1, for example, saying this is going to be, indefinite. There's not an advantage or disadvantage because you're saying that's not ambiguous because it's not dependent on any kind of vague variable.
That's right.
Okay.
Yeah, you could say it's indefinite. That's fine. But just let's not make it, if you're going to give it an expiration date, let's not give it a movable expiration date. Let's just pick one. And you can pick one after all the way to the end of the month and end it early if you want. That might be your safer bet than trying to guess when you're next going to meet.
I think I'm surely I'm talking to everybody that knows this, but the original intent behind those stop deadlines was so we could have each time that it comes up a robust discussion about continuing it or not continuing it, getting input from various sources to help make that decision. So it's less of a passive decision than it is a very active decision because of the economics involved being different than masking.
So here's what I'll propose, and I don't know what kind of, if this is an amendment or just an alteration to my motion. So if we change the end date to like 11:59 p.m. November 13th, that'll cover us. So that we're going to meet that week either on the 10th or the 12th. So we're good. If that's okay with my second.
That's great with me.
So 11:59, November 13th.
And again, that will allow us that privilege of having a good, robust discussion about continuing, not continuing, and getting any new data that will help us in that decision. So in general discussion about that, I would be in favor of that hard date on it. Any other discussion, comments, or questions about 2020-5? If not, I sense we're ready to vote. And Narda, if you will help us with a roll call vote on 2020-5, please.
Yes, this is Narda Capicelli. We're voting on 2020-5. Dr. Drake?
Yes.
Dr. Gotcher?
Yes.
Dr. Hurt?
Yes.
Mayor Jacobs? Mayor Jacobs?
Sorry, no.
Dr. O'Brien?
Yes.
Ms. Roma?
Yes.
Dr. Shamia?
Yes.
Dr. Souza?
Yes.
Ms. Wagner?
Yes.
Dr. Buchanan?
Yes.
Okay, it's 9-1. 1-7 vote. Thank you.
Well, thank you. You have adopted a continuation of 2020-5. Is there a time limit on 2026, 2020-6 that needs to be addressed at this meeting?
Yeah, that was the same as, I think we had the same both ending at the end of the month. Dr. Buchanan, do you have, I guess, any information on, has anything happened in the community with, I guess, complaints, enforcement, anything with this 2020?
No, enforcement's really challenging. I mean, the way it's written, it's 25 people per 9,000 square feet. And so I think that's a really challenging thing to enforce. Because, you're going to go measure the room and count the people. And so we haven't had many complaints from the public. And we certainly haven't had any enforcement related activities to this. So that, again, just challenging to enforce something like that.
Dr. Buchanan, to clarify, was that 25 per 9,000 or 25 per 900?
9,000.
900.
900. I get it wrong every time. Sorry. 900.
9,000 would be a huge house, and 25.
Yeah, 900. Sorry, my bad.
That's
Yeah.
FYI, folks, that's basically 6 feet of distance between each person.
Another way of stating that 6-foot distance, Dr. Hurd. Absolutely. Yeah. Okay.
Yeah, so I guess I asked the same question 2 weeks ago, and the answer was the same. And so I guess, while I like the spirit of this, I'm not sure it's having any impact. And so I guess I'm questioning the value of it, and do we need to keep it in place?
I think it was our reaction of this massive sort of tight, close space groups that were occurring in the college area immediately when things started. And along those lines, there's been, looks like some very positive information coming out of the University of Tennessee about low case rates and their ability to really track things, well. So that's a good point of discussion, Dr. Souza. What do you think? What does everybody think about leaving it, doing away with it?
I make a motion that we do away with the 25 per 900 square feet.
That would be 2020-6.
We don't have to do a motion. We actually just don't have to do anything. It just dies if we don't do anything.
Okay, right.
So, Dr. Gocher, I have a question for Dr. Buchanan on this, and that is that as we move into the holiday season, and it really gets to Dr. O'Brien's point as well. I don't know how much of this, I think November is going to be a rough month overall. And so I don't know how much of preparing for Thanksgiving is going to be just encouraging the 5 core actions, or whether, whether having some sort of gathering size limitation in place, understanding the enforcement piece. What I want to be careful that we do is that we don't send the wrong message by, I know what it's going to read. I know the headline tomorrow is restaurant closure at 11 p.m. continued and gathering size lifted. And so I just knowing that we're not, going into, with a tape measure, we're not going into places and determining how many people they have in county heads. I just want to be careful that if this does get rescinded, and I understand, Dr. Souza, I certainly understand your point, but what is the messaging going to be around this, and are we going to be responsible for an unintended consequence?
My understanding of the regulation is that it has to do with establishments and land adjacent to those establishments. and it would not have anything to do with an immediate family gathering, which actually is more of a critical area, as we know. So I think the messaging could be, when this is rescinded, that we're really concerned about those private gatherings, which actually fell outside of this regulation anyway. If my understanding of that regulation is correct, maybe have board members help me out on that. I don't have the regulation in front of me right now.
It included both public and private locations.
Is it private locations that are?
Because we had a long discussion about that, because private locations also includes a private office building.
Yeah.
That's not a public space.
But not homes and not on private property in the sense of a family gathering. So, you know, we need to really encourage the public that whatever happens with this, that's what we need. We need people to do the 5 core actions, even when, and this is the most important, with your families and your friends,
Right.
especially when we get to the holidays. So, you know, whether we keep this or not, it still doesn't keep us from needing this to happen across our whole community.
In fact, this may be, if it is left to be off as a regulation, to die as a regulation, I think this could be a springboard for discussion that even more important is something that we hadn't really approached in this regulation, and that's what to do in your own home. It's really critical.
Just to clarify, this is Marie Hurd again, Dr. Gotcher, you're talking about the importance of basically a public service announcement enforcing, you know, family gatherings potentially being an issue in terms of spread of the virus. Not, I mean, we're not talking about any kind of regulation.
No.
I just want to make it clear to anyone who's listening what you're suggesting.
No regulation, but
That would be, yes, that will make the headlines tonight, not tomorrow.
The public to help us out with this, because we know there's a substantial number of cases that are generated in just such an environment. And we don't have and don't want control over that, but we want people to help us out. Just help us out.
Yeah, help each other out. I would like to say I can appreciate what Dr. Sousa, what her perspective is, and what, you know, Dr. O'Brien has said. I would like, my perspective is this regulation, we don't know, while it may be cumbersome and bothersome, we don't know how much of a factor it's been in mitigating the spread of the virus on campus. We do know, and what I heard our chancellor say was that she felt like the measures we put in place, she felt like that had something to do with their case numbers falling within a couple of weeks of us implementing this particular regulation. You know, can we prove that beyond a shadow of a doubt? I don't think so. I don't know. But has it really hurt to stay? Can it hurt to keep it in place while students are still on campus as we approach the holidays? So that's my argument for certainly not killing it tonight. And potentially I would make the same argument for the alcohol restriction, at least keep it through November, is because this particular regulation doesn't seem to be really impacting the economy, public morale. This isn't what we're getting feedback from. Just a thought. If it ain't broke, why are we trying to fix it, so to speak?
I think it's facing the facts that it seems like the businesses that were our concern in the university area have stepped up, and that we don't control the actual university itself with this regulation. We do have say with these businesses. They have really tried to do what they can to help with this. And I guess it's just a way of taking one thing down, but challenging our community to realize that we still have a long way to go. And we could let something go that is not being, it's not being enforced. But we could let one little thing go, but we need everybody to volunteer, to step up. We have that volunteer spirit. We need it now as we go through the next 2 months. So I'm okay with letting it sunset, but we got to tell everybody if things get a lot worse. If they get a lot worse, then we have to look at whatever we can to help with that. I don't know that this one's really helping us that much. Most businesses still will be following the Tennessee Pledge and the requirements that are placed on them with that, as long as that's continued. So it's kind of just a piece of the pie.
Any other discussion or comments on 2020-6? Hearing none, if it's okay with everybody, we'll move to the next agenda item, which is 13, which is meeting schedule for 2020. Dr. Buchanan, would you like to help us with that discussion? Maybe to start? You're muted.
I was trying to look at the Tennessee Pledge and see what the gathering size guidelines were in there. We're in the Tennessee Pledge at this time, because I can't remember. So we talked about needing to maybe move some meetings. Our next meeting definitely falls on Veterans Day. So we checked with CTV, and they could accommodate us on the 10th of November. So that's the Tuesday before. So I would propose that we just move that meeting to the Tuesday before and have the meeting. And certainly, Dr. Goetcher, you can, as the chair, you have the authority to say yes or no to that. The other meeting date was on the Wednesday before Thanksgiving. And unless Dr. Goetcher wants to move that, I think we have the meeting and the people in town attend the meeting, and the people who can't attend the meeting don't,
I'll attend the meeting.
So that's kind of where I am with that.
It
Kind of talked about it and didn't feel like the day before Thanksgiving was all that big a deal to have a meeting. But
it sounds like from Ms. Roma's comments that we are going to be in Zoom mode for the next month. So there's that, which will give us some stability in terms of how we meet. I will tell you all that I found out only this morning that I once again have drawn the short straw for the 10th of November in terms of being on trauma call. Ugh. So Dr. Souza, our appointed person, may be chairing the meeting. I hope not, but last time was challenging for me. So hopefully it'll be quiet. But I found out just today that they couldn't find anybody to take calls, so they asked me to do it again.
So do you approve of that change, sir?
Of being on call all the time? Not really.
so Dr. Goetcher, are you okay with moving the meeting to November 10th and leaving the meeting before Thanksgiving?
Yeah, I think that.
Okay, thank you.
So I guess with him potentially being on call, do we need to go ahead and just settle things before, so we don't have to go, because I think last week or 2 weeks ago, there had to be a motion and all that things in order for me to actually run the meeting. And if someone else wants to do it, I certainly don't mind giving up that spot, but is it easier to just go ahead and get that out of the way?
I think that would be wise, because I never know. Most of these cases that I do end up being evening cases, and they go on and on sometimes. And then they start at unpredictable times. That's what the problem is. I was supposed to be finished by the time we were starting before, and well, you know how that goes. And so I finished about 10:30 at night. So, Dr. Sousa, if you or other members would be so kind as to do that, I will make every effort to attend that meeting. But I'm trying to chair it may be difficult.
I believe it's your prerogative, sir. Dr. Souza is an excellent stand-in chair.
I have listened in. I listened in for the last minute and a half of the last meeting. That was in between cases. I got the last minute and a half in. Good job. Good job. So the next item for discussion. Have we completed our discussion on meeting schedule for 2020? We haven't gone into December with that. That's an open area of discussion. Are we working just through November right now, or are we going into December?
At this moment, we're going to work through November.
Okay. And we've got it settled for November at this point. So we can move from that item to the next item then, which is discussing inviting additional guest speakers. And I guess I could lead the discussion with this. I think we've had a really educational and maybe a really successful idea about having speakers such as those that we had this evening and our economics professor before. And I know that we've had a lot of input from the public. There's been a lot of national input on the psychological and psychiatric implications of isolation, of the stress of living in a pandemic. And this may not be something we can assemble by the next meeting, but I would like to have some input from either a psychologist or psychiatrist that with some background information for us in this area to give us and give the public a kind of an educational background or maybe points for discussion regarding the psychological or psychiatric aspects of the pandemic. And I'll welcome certainly any input if that's a good idea, bad idea, or so forth.
I think it's a great idea.
I agree. Hopefully we could get somebody from Helen Ross McNabb or Cherokee to come in.
Dr. Gocher, I think it's a great idea.
Thanks. Does anybody have a contact that would be a good person?
Sure. This is Charity Menifee. I actually got an invite to on my desk, I think this week, or from the Mental Health Association of East Tennessee that is doing a program soon on this topic, and they're going to have several speakers. So we can maybe reach out to the folks that are organizing that. I'm not sure. I can't remember if it's local speakers or any national level speakers, but if it's local speakers, that might be a good source. I know that I just was looking at it on my desk, but haven't read it carefully, but I do know that's the topic. So hopefully that's a place to look.
And I will say, in addition to that, in thinking about our next meeting, which is our first meeting of the month of November, right? Yes. So we will have public forum. So just in thinking about the length of the meeting, perhaps when we have public forum is not the best time to have additional speakers.
It may take time to assemble that as well. So
so we can work on that. And if we don't have any, when we have plenty of contacts with either Helen Ross McNabb or Cherokee or the Mental Health Association. So,
or possibly the Department of Psychology at the University of Tennessee.
Sure.
Variety of resources. Are there any other topics or guest speakers that board members would be interested in having to kind of complete our education and the public's education on the pandemic? We can start with the psychological, psychiatric aspects and take it from there, but something to think about, because a chance to have enrichment of the board and from the board to the public is always a good idea.
Agreed. Dr. Gocher, before we move forward, this is Maria. Sorry, folks, I've really been trying to pay attention, but did we actually vote on what we're going to do with 2020-6?
There was a lack of a motion, and because of the lack of motion, it'll be allowed to sunset.
We'll just let it go. Okay, thank you for clarifying.
You're welcome. So the last topic, other than other business, the last topic is going to be motivating the community and reinforcing the 5 core actions. And Dr. Shami, I think that was your topic to open discussion on, if I remember correctly.
It was, yeah. Thank you. And I mean, thankfully, we've already had quite a bit of discussion around this. But I put it as a placeholder because obviously we have challenges ahead, and we're going to be very dependent on the actions of the community. And it seems like a long time ago when we passed that education resolution. And so I guess my question, and guys, I don't have the answer because I don't know what we're capable of doing as a board and the support that we have, but there's going to be a variety of people with campaigns trying to educate, trying to really amp up the messaging around this as specifically cases go up, and then as I anticipate hospitalizations go or increase. And so what is the role of, I mean, we're essentially very, Dr. O'Brien mentioned how many people watched the meeting, and that is very, very true. And so we're very dependent on what is written about these meetings in terms of what gets out. And I'm thankful for that, because we want the information to be distributed. And I think the media has done a very good job of conveying the points that the public needs to know. But what can we do to define and then convey that message? And for that matter, will it have an impact? And we may not know, and so it's still worth trying. But as a board versus the health department, Dr. Buchanan, which is that's what I'm trying to get a sense of, is do we even have a specific role here? And if so, what is it? But I didn't want to get through another meeting. Well before my agenda item, we've had this conversation, but we don't really dig into it every meeting. And so I wanted to raise it as, what can we do? What is our role?
One role we may have is something that's ongoing right now, which is better education of the public within public forums, such as Knox County Commission. They're talking about us. There were a lot of people who spoke on Monday and expressed their beliefs, many of which I would think is actually some minority beliefs, but they are beliefs. And I think that we need to take part more in that, and maybe where, Dr. Gocher offers as our chair to talk with Chairman Jay and to see if there's some commonality where we could work with them. The other thing would be if there might be a public forum outside of this that's with other organizations, where we do a Zoom meeting with one or two of us with other groups in the community, so that we get the word out. The other possibility would be, being, I hate to say this and I don't like it, where we would be available to be on TV or in social media with where there's an interview. I really don't like the thought of that, but we've got to get the word out that we are here for the community, that we're all in this together. And just because certain people have views that are counter to what we think is the best way for public health, we need to still educate and try to get everybody to come along and to be part of that group that helps drive this disease process down right now. So I just throw that out there, that there's various possibilities. I think Chairman Jay would be very open to input. I was there for input here recently, and I think the next meeting is going to be very important. They're looking to make changes to the way we operate by ordinance to tell us how we operate, which is, I think, one way to make a point. And I think we need to make the point back to the county commission that we are here for everybody and for the people. I don't want public forum to become some out of control sort of thing where people come and go on for hours and hours with the same message. That's okay, I guess, up to a point. But we want to get our work done, and we want our work to be out in the community for the whole community. So just wanted to bring that up.
So any other discussions on item 15, which is the community motivation reinforcing core actions? Dr. O'Brien, I certainly concur with your discussion.
So Mayor Jacobs, I know there's a group that I think Chairman Plowman and or Chancellor Plowman and Mayor Buchanan kind of brought together of leaders in the community. I don't know if they would, I'm not really sure what the purpose of that group is. I know there was something in the paper or somewhere about them recently. Is this something they could help with, promoting the 5 core actions? I just don't, it's just a question, I just don't know. Sorry to put you on the spot.
Sure. And you know, Dr. Buchanan, I'm not exactly sure. I think that they would like input, you know, from you all as individuals, whether it's you, Dr. B, or Dr. Gocher, or whoever. I don't know that, you know, that's not really the role of that particular organization. So I don't know. I'm sorry. I wish I had a better answer for you.
Oh, that's okay. It's just, I just
But
know.
I think for sure that they would, you know, be willing to talk. Well, they would love to talk with, you know, and I'm on the board too, so we would love to talk with you guys, and as well as both ways. Any ideas that committee might have, and vice versa, any ideas you might have for them would be great and welcome.
And to your point, Dr. Shimia, I do think that somebody besides the health department needs to carry the message, because people are kind of tired of hearing that message from us, because we've become quite the broken record about the 5 core actions. And so I think other voices carrying that would be great. And, you know, not just people from the medical field, people from other areas of the community. I don't really know how we do that. To be honest, you know, I just don't have the answer for how we do that.
So, well, let me ask this. So the hospitals, you know, they have, I mean, granted, they have the resources of the public relations department or media department, but those all got together, decided on the message. The message came out earlier this week. They may do that again. I think they're working on a public service announcement. So there's that piece. Is there any equivalent? And guys, I'm asking because I don't know the answer. I mean, you know, from a board membership standpoint, is there any equivalent for us as a board where we're conveying and controlling the message instead of just always the message being constructed based on however our meeting went? Is there, I mean, is it something we write? Is it something that we put in the newspaper? I don't, is there, or is that just Mr. Standards? I mean, can we do anything like that we want to? Are there any limitations on those types of things?
I'm not aware of any limitation. There obviously there are public meeting limitations or open meeting limitations if 2 or more of you do something together that isn't properly noticed. But as long as any one member gives an interview or something, I can't think of any issues that are problematic about it. Other members of other governing bodies do it all the time, the county commission or the school board. And in fact, 2 or more of you can host a meeting, just as recently a county commissioner was going to do. You simply publicly notice that you're going to be at location X at time Y, and you do it. The trick is to make sure that you properly notice any such gathering, but you all have First Amendment rights to free speech. There's nothing to keep you from going and granting an interview or shoutings from the rooftops or publishing a dissertation or whatever else you want to do. But
I will say that the reality is, I mean, given the degree of negative attention that this board has faced, I mean, that's affected, you know, the members of this board. And so I was really looking to see if there was something we could do as a group. It sounds like essentially what it looks like is another education resolution in the next meeting. I'm not getting a sense there's a whole lot of, I think these are very good ideas that have been shared, but yeah, Dr. Hurt, I'm sorry, you're trying to speak.
Well, I'd just like to contribute. I mean, as an educator, there's more, I'm not the only educator on this board. And most of us in healthcare are used to educating, even informally, whether or not that's our degree. But I know at our last meeting where we had a public forum, one of our fellow citizens made a great suggestion, which is basically touches on what we're kind of working around, which is how about a dedicated effort as a group to focus on public education, whatever the message may be. I know, Dr. Schmid, you've said more than once, masks are the workhorse. That's a good soundbite to start to pull in an audience and use as a teaching tool. So that in combination with, I'm not convinced the public forum is the way to do that, but, this touches on something I'd like to talk about in other business, but the county commission ordinance requiring us to hold a public forum in the same manner as that's afforded citizens by the county commission. Part of all of that is what Mr. Sanders just touched on. It was having, what do they call it? I forget the terminology. Help me out here, Mr. Sanders. But basically a working session, so that, for instance, if Ms. Wagner and Ms. Roma and I want to meet and brainstorm an idea of what's one of the 5 core actions we want to really emphasize and create some kind of PSA, so to speak. As long as we follow the rules for announcing it in advance as a public meeting, why can't we do that? If there's any interest. I mean, I personally think it's not a bad idea to consider these working sessions. Well, I professionally think it too, because we are handicapped otherwise. The only time we get to talk to each other, and it's a very unrealistic, unreal, unpragmatic way of working as a group, is only getting to meet face to face, so to speak, in real time, not being able to, think things out or through at any other time. And so I anticipate that perhaps that doesn't sound like everyone's favorite idea, like more meetings, but if those of us who are interested in meeting outside of these scheduled meetings, want to do that, I think it's a good idea for us to consider, especially as an educator. And in light of, I thought that was a great suggestion in public forum, that, which only goes to show our fellow citizens can contribute really meaningful, constructive perspective and suggestions about how we can help our community.
Mr. Sanders, what would be a requirement upon us legally to make notice if we say want to have a separate little Zoom meeting that we're going to talk over educational efforts we want to work on, and we publish that? So what's the time requirement and anything else that we would need to know? You're muted.
I apologize. My screen was bouncing around on me and I thought I'd unmuted myself. In fact, I muted myself back. So we typically say 48 hours, but more notice is better. So anything in advance of 48 hours, a week or so would be ideal, or even 3 or 4 days. And you publish it in the same manner that you publish your notices now. I assume that those notices are going out from the health department. I usually see them coming from someone in the health department, but they're published to all major news outlets, and they would simply go out in the same fashion. They would announce that, these following members are intending to meet at a certain location or by Zoom. Now, of course, the Zoom meeting, you're going to have to set up with CCTV and follow all the rules that are in the governor's executive order. And I can talk you all through that privately if anybody wants to do that. But essentially, there's nothing magic about more people meeting. And actually, let me walk this back for a second. I need to check on the feasibility of whether you could do a Zoom meeting, just 2 or 3 of you, because that's not an official meeting of the board. And I don't have that information. I'm unfortunately one of the folks who's quarantining at home right now. So I don't have that information in front of me to look at the governor's executive order and see that. I can do it by tomorrow and send you an email or something, but don't take it to the bank that you can do one of these small meetings by Zoom, because I think the governor's executive order may only deal with regular meetings of these committees. Otherwise, you can certainly meet at a coffee house or something, but I think probably the Zoom meetings is only for the board as a whole at its regular meetings.
Mr. Sanders, is there any update on that electronic form that we tried to institute a few weeks ago? Is that valid, not valid? Update.
Where I've come down on that is it's not valid. And the reason forgive me, it's another one I'm going to have to reconstruct on the fly here. The statute, which I don't have the citation for off the tip of my fingers, speaks of elected bodies in counties. This is not an elected body. Therefore, because this body is not elected, it cannot avail itself of that electronic forum. I wish the answer were different for your sakes, but it appears that that's where the state Office of Open Records Council has come down. It recently denied a similar request to Knox County for a different committee that was similarly not elected, but appointed. And so the only elected bodies in Knox County are the commission and the school board.
Now, one way that we could indirectly discuss things, I think, which would be valid, is that if we locate in our readings a scientific paper that has merit for our deliberations, for example, a new meta-analysis on use of masks or social distancing, something like that, that we can, through the health department, share that with NARDA or with Dr. Buchanan and say, if this is feasible, could we distribute this information to members? And there's no discussion involved, merely a distribution of the document. Is that a fair thing to do?
So let me answer this in sort of two steps. You have done that in the past, and there's no problem with showing a scientific journal article, say, and asking that it be shared to other members of the board. And I especially would like it to be published. And I think we've now come up with a space on the health department website where it is published when something like that is recommended, so that any member of the public can see.
That would be great.
Whatever the source is that you all are, that is being recommended to the board as a whole. And there's no discussion, but let's be clear that I don't like the verbiage get around something. I mean, the purpose of the Open Meetings Act is to have open meetings. So sharing information is permissible, but don't take it to the point where you're trying to avoid having an open meeting or trying to avoid sharing information with the public. That's absolutely contrary to the intent of the law.
I mean,
what we need to do is, okay, go ahead.
The intent of that would be to share that information with the public, but also to share it with fellow board members, to share it with everyone.
Right. And I don't see any issue with, if there is a germane scientific journal and that someone wants to make sure that everyone else is aware of, share it to someone at the health department, have them posted on the website where everybody can see it. And, then board members can see it, the public can see it. But obviously you can't do a sleight of hand with it. You can't say, please let everybody know that we want to vote on this action next week, for instance, or something like that. I'm not suggesting you would, but I want to be clear that you need to be very, very open in this process.
So, and I would also say, you don't have to go through me or NARDA to send things to other board members just for information. So you feel free to, everybody has a Knox County email address. When I get it, I'll make sure we post it on the board website, web page. I don't think it's a website, the page. So you guys can share articles amongst yourselves.
Dr. Buchanan, if I can, I'd really prefer that not be the case. I recognize that what we're talking about, just sharing a scientific article, is not a violation of the Open Meetings Act, but the more time someone communicates, the more opportunities there are for inadvertent deliberation. If someone hits a reply and says, boy, this is a great article, I'm glad you brought this to light. I mean, where do we go with that? I would prefer it go to a non-board member, and then that non-board member distributes it to all the board. And I'll tell you, as you've seen probably in my communications with you, I take the extra step of putting everybody's name in a BCC box so that you can't even inadvertently reply all to a communication you get from me. So I'd leave that. I advise you to be very, very careful about any emails that are sent amongst yourselves, even for the most innocent of purposes.
Then I also take this opportunity to remind everybody again that your support is just limited. That your support has other day jobs. That's not just supporting the board. So we're working on that. We're working on actually hiring support for the board using our COVID money, but that's not happened yet. So just keep that in mind, please.
Judicious use. Right. Any other business? We have the other business section now.
Dr. Gocher, I just had one last comment, and that was really just a question for Mayor Jacobs, and that is just on this same topic about, you know, how we educate, how we influence the community. Because, I mean, if the cases through the winter do continue to increase, and you know, there is a potential for the economic impact of this as well. And so, I guess, do you see something that we're not seeing? I mean, we talked about a lot of procedural stuff and process stuff, and maybe there's the ability for a subgroup to meet as long as it's sunshined and talk about education. But are there ways that we can get this word out that have not already been tried, so that we can help Dr. B, we can help the health department as a board, something that we're missing that you see?
I think one thing to keep in mind, Dr. Shamia, is when we look at all the coverage, of course, in the media, there's just been tremendous amounts of coverage, you know, all through the media at many different levels. So, you know, I think, you know, when we're looking at public relations, you know, it's really about penetrating awareness, right? And ensuring that people know. I mean, people know about this no matter where they are on it. So I don't know how much this board is going to be able to really have a big impact in relation to that. You know, you have just everybody is talking about COVID-19, you know, and I think too that, you know, all these, you know, it comes out from Dr. B, it comes out from all these different sources. So I think your all's role, I don't know if that's your all's role, because there's just so much that's currently out there, that I think that people, you know, unless you've been living under a rock, you should understand that this is a real situation. It's a dangerous situation, you know, and what experts recommend. So I don't know how much you all can really can do any more to penetrate that and to get that across to folks. Does that make sense, sir?
It does. I mean, I understand what you said.
Yeah, thank you.
Any other business to come before the committee or the board? I'm sorry.
This is Maria. I would just like to follow up just for a couple of minutes with Mr. Sanders on something that I brought up last meeting, about county commission ordinance and now they, you know, to put it into place to determine how we conduct a public forum. And so I'm hoping to follow up on that, on my trying to understand how they can, I mean, I understand it's an ordinance, but I'm hoping you can elucidate for me some things that have come to mind in actually what does that mean? What does it mean that we need? I think that I'm looking at my notes here, that we're required in the same manner to provide public forum in the same manner as afforded citizens by the county commission. So, I got to thinking, well, that implies that we should know exactly what they mean, but they're, how county commission conducts public forum before and after a meeting, 5 minutes per person, et cetera, et cetera. But then there's also a clause literally in the rules that says, unless otherwise provided by the commission. So the rules for public forum include the ability for county commission to change the rules. And so what I'd like some understanding or clarification on is, if we're required to adopt public forum rules, then, what does that mean? Are we also required to have an agenda session as they do, to create a legislative session in the agenda that's bookended by the public forum? I mean, to what extent? I basically would like to know, what does this really mean? It seems it's very open to interpretation, and also includes the ability for us to determine how we're going to do public forum. Maybe we only want people to meet as we, speak for 3 minutes at the beginning, for half an hour, instead of, bookending our whole meeting. And if the county commission changes their rules per meeting, do we have to follow suit exactly to do what they're doing? So, long-winded way of saying, please shed some light on how to interpret this ordinance specific to us.
Well, you obviously are asking a lot of very open-ended questions, and I won't pretend I've got all the answers right now.
Sure.
First of all, the ordinance has only been voted on once. It has to be voted on and passed again before it affects the county commission. And between now and affects this board, and between now and then, it may be amended. So, for instance, some smart county commissioner may be listening to this meeting right now and saying, "Holy cow, she's right. We need to put some more specificity into this." You're right. In the same manner does not really tell you a lot. In my inclination thus far has been that if there's no amendments and nothing else said about it, that you all simply follow the county commission rules. Now, as far as the public forum goes in general, obviously as a Knox County attorney, I can't, there's no enforcement provision to this. There's, you all still control your own meetings, but it is a Knox County ordinance, so you should follow it. My suspicion would be that in the absence of specificity, your chair and you all still maintain a large amount of control over your meetings. I have a feeling that the inclination behind the county commissions was that everyone have a chance to speak. I think that was their chief issue, that the Board of Health has only one half an hour once a month of public forum, which you're entirely within your rights to do as things stand right now. But the county commission felt that the public needed to have the opportunity to speak more often, and more people needed to have the opportunity to speak. So I think that was really what they were getting after in the same manner phrase, was having public forum at every meeting and allowing as many people to speak as wanted to speak. My suspicion is that the issue of 5 minutes versus 3 minutes was somewhat less. But I'll have to go back and dig through the transcripts or something if that becomes an issue. I think this board can still set its own rules as far as the when and how. For instance, maybe if it's evident that you're going to be facing 6 hours of speakers, then maybe the answer is anybody who wants to go in the first hour and speak for 3 minutes gets to do so and voluntarily limit their time. Everybody else can speak for 5 minutes, but it's going to be after you finish your business. It's just a suggestion. Obviously, it's not my place to tell you how to design your rules, but I'm just saying that you all, in as much as the ordinance is not specific, then I think you all have the authority to interpret the rules the way you want to. And that is a very unspecific phrase. I think I think what you will need to do if that ordinance passes as it's phrased right now is you will need to have public forum at every meeting. That's for certain. I think it's less certain when those speakers would have the option of speaking, and it's less certain as to how long they would have to speak.
Mr. Sanders, I have a question. When we first look at setting rules, I think your comment was that the fallback position on all rules was what the county commission's rules were, but that we could independently set our own rules. And so this proposed regulation or proposal from the Knox County Commission would do away with that, where they would directly control the rules for our boards. Is my understanding of that proposal correct?
No, not entirely. I stand by what I said, that you control your own rules, but that's only to the extent that there's not an ordinance in place. An ordinance is actually a law of the county. It's the same as, don't spit on the sidewalk or something. Mm-hmm. So if there is an ordinance passed, then that would theoretically supersede your all's procedural rules. And you would need to follow the ordinance. But all your other procedural rules are still in place and would still govern. So only the aspect that conflicted with the ordinance would no longer be applicable. And you just need to do whatever the ordinance says is about public forum. But again, as Dr. Hurt pointed out, there's a lot of ambiguity in the way that's phrased right now. We'll have to see what the county commission passes on its next reading to figure out exactly what the obligation this board has as far as public forum is.
So one of the questions I have for the board is, I think it might be appropriate for the board to have a representative who's not me at county commission to hear the debate and hear what they're thinking and be able to understand where they're coming from and ask questions that the board might be concerned about. The next county commission work session is on Monday, November 9th at 5 p.m. in the main assembly room. It's a face-to-face meeting. And that's where they'll have the most discussion about this ordinance. The voting session tends to have less discussion than the working session. And so those meetings are earlier than normal because of the holidays. And so if somebody's able, I don't know if Dr. Goetcher can go or somebody else can go, if the board would like to send a representative, I think that would be useful. They did ask if there was a representative from the board other than me there. I'm generally there in my capacity as the director of the health department. So I'm not sure who would be able to go or who the board would want to attend that meeting.
This certainly touches on what Dr. O'Brien was talking about earlier about there needing to be more direct communication between the Board of Health and County Commission. So that's one thought. Another thing I'd like to mention is that in terms of, public, and I understand, Mr. Sanders, you're, and you made it very clear, your best sense of what the intention of this ordinance was that, they wanted us to be more open, have more frequent public forum, et cetera. I'd like to point out that, when we've had public forum, it was at least 2 times ago, if I'm not mistaken, someone correct me. There wasn't any public, we had it, we were open, we were expecting people to come, and there were no speakers. I think that was two public forums ago. And then the last public forum, there were at least 1 or 2 people who were on the docket to come speak that didn't. So all I just say is, we're open, we're available, and I don't think certainly the case can be made that we're not open to receiving feedback from our fellow citizens. That's what I want to say about that.
Mr. Sanders, just for my own edification here, what document empowers the health board to make their own rules? Is it TCA? Is it the charter?
Well, neither specifically addressed that. The way, as we've always come down on it, was that in absence of any board enacting its own rules, they follow the county commission's rules, but they are free to enact their own rules, which this group has now done. In fact, there's no document that says they have to follow county commission's rules. That's always been just a convention of the county that is done that way. Some things just aren't written and are followed out of tradition, but this board is a statutorily authorized board, and I have no doubt that they're authorized to enact their own rules.
Yeah, I discussed, my question would be just procedurally, if an ordinance can't overrule the charter or TCA.
That's right.
Yeah, so just curious as to, what that process looks like as far as commission, saying, hey, you have to do this. If it's,
that's a question for my boss.
You see what I'm saying? Yeah.
Yeah. I think I'd want Mr. Book to weigh in on that if we get into, if push comes to shove and and someone wants to challenge whether the county commission has the authority to govern this board, then I think that's a question most properly directed to Mr. Book.
Okay, thank you.
Just to follow up on Dr. Hurt's comments, I think the other thing to remind everybody that, we typically frequently even talk about them at this meeting, the multiple emails that come in through our Board of Health emails are looked at and sometimes discussed at this meeting. Dr. Gocher, I don't know if you want to attend the next county commission meeting, or if you want to have somebody else attend. It's again November 9th at 5 p.m. I'm not sure how long it'll go.
So Dr. Buchanan, I'll need to look at my schedule. That's that week that I may or may not be available, but if I can, I'll step up. So any other business? We're in the other business section here. Any other business that we need to bring before the board or discuss at this time?
I guess the only other update from County Commission is that they did pass the resolution forming the Advisory Committee on Health and Economic Wellbeing. That will be, Mayor Jacobs will be making appointments to that body sometime over the next several months.
So is there any sense how the 3 bodies us and the 2 others that have been created will interact with each other, or if they will?
A lot of the new advisory committee, how it's going to function and how it'll work is yet to be determined. It does say, I can't remember exactly what the wording is of the resolution, but I think it did also include advising the Board of Health. I think, or at least one time it did. I don't know if the final one that passed had that language in it. We can have NARDA send the resolution, finalized resolution out to everybody. So no, it's not clear. There's a lot of yet to be determined.
I will say that I can say from my own personal standpoint, my personal work situation has become increasingly complicated in the last 3 weeks, and Dr. Buchanan, I suspect yours has as well. And so the amount of time in helping direct our hospital's response, and of course, a variety of us have our clinical duties. For the amount of time that, if things do get worse, if it'd be nice to have the support of County Commission and us all be on the same sheet of music. But increasingly, I know for me, for example, I'm going to have my primary focus is going to be on helping to guide UT Medical Center through our response. And so, but any time any of us spend on some of these issues, which I understand are important issues, but we just have to be careful we're balancing all our responsibilities. And if indeed COVID-19 gets worse, and of course I've got the hospital lens, but if it does, we're going to have less time we're really going to have to focus our efforts on what's in front of us. And so, I for one I'd love to see the universal support of the County Commission. But that's, I think that there's been, I don't know what is motivating some of the follow these rules or to create another body ultimately. But I think we've got to really be, as a board here, for as long as we exist, laser focused on COVID-19's impact on public health, and then on the economy, and then of course the economy's impact on the health. And then Dr. Gocher, I think it's great. We're going to try to get somebody with mental health, but I just don't want us to take our eye off the ball because of everything that's going on around us.
I would agree with that. Just if you just look at our responsibilities outside of this, and of course, I'm sure the County Commission members have their series of sets of responsibilities as well outside of County Commission, but there are only so many hours in a day. Any other discussion that we need to go over? We're in the other business section. Anything else that we need to touch on this evening? Dr. Buchanan, anything that we have left undone?
Not that I'm aware of. I make a motion, we adjourn.
That sounds like a plan. And we have a second. Okay. Well, thanks everybody for your attention. We had a kind of a longish meeting tonight, but I think well worth it and productive. So we will see you all on the 10th. Thanks very much.